Am I audible now?
Yeah.
Yes,
You could be
yes.
louder.
Okay.
So Sunil, you update on the numbers.
Ma'am, we are live.
Very good evening to one and all of you, dear friends and postgraduates in this audience. We plan yet again to provide you with a very energetic webinar with lots of exchanges of ideas, and we would try our best to clarify all those gray areas. We are lucky to have the experts on the expert panel, true experts, each a master of the ophthalmic art. Our president, Aios, Dr. Mahipal Sachdev, has brought vibrancy into the organization and needs no introduction. Our past president, Aios, Dr. Ramurthy, we would remember him for his accolades. Our honorary general secretary, Dr. Namrata Sharma, a perfectionist in all her missions. Dr. Jagdish Reddy, the light and energy to reckon in LVPI, leading the Cataract and Cornea Division. Dr. Sri Ganesh, chairman and MD of the Netradama Group of Hospitals, quite a force to reckon. Dr. Harshul, member of ARC Central, who suffuses energy into life beyond ophthalmology, with which we are all familiar. And of course, myself. Two of us will be moderating the session. We shall now go on with our first speaker, Dr. Sheetal Brar, who's a senior consultant cataract, cornea, and refractive surgery of Netradama Hospital, Bangalore, who will be talking on recent advances in IOL power calculation. It's a very important topic for all of us, and it has been on a stepwise climb in the ladder. And Sheetal Brar is a senior consultant and research director of Netradama Super Specialty Hospital, has been a path blazer with absolutely amazing sequence, the best of best ASCRS video awards year after year, a solid internationally known and respected smile surgery trainer, having trained 75 national and international surgeons in the refractive surgery, has participated in huge numbers of master classes, instruction courses, 40 publications in index journals, and review of journal of great repute. On to you, Sheetal. It's never ending, this intro of yours.
Thank you so much, ma'am. Yeah, good evening, everyone. And I would like to thank ARC IOC for this wonderful opportunity. So I'll be sharing my slides now. So are my slides visible?
Yeah.
Okay, so friends, today I'll be talking about advances in IOL power calculations. So it's a very complex topic, and I'll do my best to justify this topic in the next 15 minutes or so. So as we all know that IOL power calculations or biometry is a field which is continuously improving and evolving, and it's extremely important to stay abreast with the new generation formulae, because we are in the era of refractive cataract surgery, wherein the percentage of patients going in for multifocals and toric lenses is increasing, and we cannot afford to have refractive surprises due to poor biometry. So it's very important to have most accurate and updated IOL formulas to be used in our practice. So categorization of the formulae is basically now changing. So previously we used to categorize IOL formulae on the basis of the generations, and this is how they were categorized earlier, the first generation, second generation, third and the fourth generation formulae. So briefly, the first generation formula was the SRK formula, which was based on the simple linear regression, is no longer used now. And the second generation was again SRK2 formula, which was same as SRK, but just added a fudge factor for the small or large eyes. This was also a regression formula, and these both formulas are not used because they were only based on regression analysis, and they did not involve the optics of the eye or any theoretical model of the eye, so they were not very accurate. So then we had the third generation formulae, which are the SRKT, Hoffer Q and Holiday 1 formula. Now, these formulae use keratometry and axial length to determine effective lens position. And then we have the fourth generation formulae which are Holiday 2, Hagees, Olson, and Barrett's Universal 2, which use additional data for better ELP prediction. Now, these formulae, the third and the fourth one, are the Vergennes formulae. So moving to the recent classification or the modern classification of intraocular lens formulae, which is based on how these formulae are derived. So based on the derivation, they could be historical or refraction based formulae and regression formulae, which, as I already told, are obsolete now. And now we have the Vergennes formulae. And these formulae are further classified on the basis of how many variables they are using. So Vergennes formula based on two variable formulae, which are the Holiday 1, SRKT, and Hoffer Q, the third generation one. And then the three variable formulae, that is a Hagees Lada super formula, 5 variable formulae, the Barrett Universal 2, 7 variable formula, which is the Holiday 2, sorry, and then the artificial intelligence based formulae, which are the most popular of which is the Hill RBF calculator, and then the ray tracing formulae such as the Olson, Oculix, and the Phaco optics. So now the classification is mainly based on the formula, the basis of which they have been derived. So this figure is very commonly used to show the evolution of the different formulae and the applicability of different formulae in various scenarios and across different axial lengths. So just going to a little bit of basics. Regression formulae, which were the first generation and second generation, which are obsolete now, versus Vergennes formula. What is the difference? So this is for the postgraduate. So regression formulae basically rely upon the statistical data of the previously operated eyes and their post-operative outcomes. So this was only based on the post-operative outcomes and the data of the operated eyes, and this did not used to take into account any optics of the eyes, so they were not accurate at all. So Vergennes formulae are based on the Gaussian optics, and they assume that the image Vergennes is equal to the object Vergennes plus the lens Vergennes. So when I say Vergennes is the optical principle which converts the distance into power. Okay, so most of the modern day IOL calculation formulae are based on the equation. This is a very complex equation which was formulated by Fedorov. So in this equation, you already know the keratometry, axial length, the desired refraction, and the vertex distance. But what is not known is the effective lens position. And effective lens position is something which is very important to know because this is what will determine where your lens is going to sit inside the bag, and based on this information, you can derive the most accurate calculation, the IOL formula and the IOL power. So ELP is something which is estimated using a number of variables, and different formulae use different variables to estimate the ELP. So when we talk about third generation formulas, the SRKT, Holiday 1, and Hoffer Q, these are still quite widely used, and but the issue is that they depend mainly on two variables. So there are two variable formulae just depending upon the axial length and keratometry to predict the effective lens position. However, with time they are evolving, and they have incorporated complex theoretical mathematical derivations to incorporate into the biometry data for better IOL prediction. Fourth generation formulae, on the other hand, have incorporated additional patient variables to further decrease the prediction error and improve refractive outcomes. So such as in the Hagees formula, they have introduced three independent constants, A0, A1, and A2, into the equation to add more flexibility to the formula. And all the three constants can then be optimized via linear regression to improve the predictability further. In the Holiday 2 formula, what they have done is that they have added 7 variables. Okay, so axial length, keratometry, ACD, white to white, lens thickness, preoperative age, refraction, and age. So they have added a more number of variables. However, what they found in the studies was that the Holiday 2 formula was did not fare significantly better in normal to long axial length eyes, but in the short axial length eyes, this was slightly better compared to Holiday 1 and was equivalent to Hage's to Hoffer Q formula for the short eyes. So results from another study also showed very similar absolute error values between Holiday 1 and Holiday 2, with the trend toward better accuracy for Holiday 1. So Holiday 2 in most of the studies has not really shown to be way better or significantly better compared to Holiday 1 formula. The Barrett Universal 2 formula is something which is everyone is using these days, is very popular formula because it works across most of the ranges of axial lens and keratometries. The formula is based on a theoretical model eye, and it retains the positive correlation of axial length with keratometry to ACD. So what also makes this formula very successful is the incorporation of the principal plane of the IOL into the formula, as well as some kind of a compensation for the posterior astigmatism of the cornea. So when this formula was compared with newer generation peers, this continued to perform well over wide ranges of biometry values. And the Barrett formula also had the smallest percentage of eyes with more than 1 diopter of prediction error. Now coming to the newer generation formulae, the first formula I would like to talk about is the ray tracing formulae. Now, the traditional IOL formulas also have one limitation, that they are based on the thin lens formula concept, which basically assumes that the optics of the cornea and the IOL are single refracting surfaces, whereas they are not. Okay, so from this thin lens formula, a virtual IOL position is then back calculated after the surgery, which is then which is said as the effective lens position, which is derived after the surgery. So this is not a very great way to predict the effective lens position. So what ray tracing does is that ray tracing is based on the Snell's law, and it tracks the light as it passes through the different refractive media of the eye based on the Snell's law. And the most popular formula which uses ray tracing technology is the Olsen formula, and this formula uses ray tracing and thick lens consideration, not the thin lens, but the thick lens consideration into account for the true physical dimension of the eye's optical system. So the main feature of this formula is the newly developed concept, which is called the C constant. And this is available on the Lenstar and Phaco optics. So what exactly is the C constant? C constant is actually basically the fraction of the lens thickness. So if you have the lens thickness, the total lens thickness, the C constant is a fraction of this lens thickness by which the center of the IOL will locate itself post-operatively. So what this means is that if your C constant is say 0.5, then your IOL will locate itself exactly in the center of the crystalline lens or the middle of the empty capsular bag. So effective lens position will be a sum of ACD plus half of the thickness of the lens thickness. So in this formula, it is basically using the lens thickness and the ACD only for ELP estimation. And so the benefit of this formula is that it works independent of the traditional factors such as axial length, keratometry, white to white, IOL power, age, gender, any type of eye, and including the previously undergone LASIK refractive surgery eyes also have shown good results with this formula. And in Dr. Olsen's practice itself, the formula has enabled him to achieve a mean absolute error of on average of 0.3 to 0.4 diopter. So another equipment which uses ray tracing technology is the MS39AS OCT. So it is the most advanced device for the analysis of anterior segment of the eye. It combines Placido disc topography with high resolution OCT to give high resolution anterior segment tomography cross-sectional images over a range of over a span of 16 millimeters corneal diameter. So this machine also has an IOL calculation module available inside, which is based on the ray tracing techniques, and this also measures the lens thickness. And we are using this formula and this technique for technology for post-refractive surgery eyes. And what we are seeing is that the predictability of ray tracing technology in this scenario is very similar to the gold standard Barrett 2K formula and also the Barrett TK, which I'll be talking about later. So the ray tracing technology is also available in Pentacam HR, where it uses the total corneal refractive power map, which is calculated using the ray tracing, and this is a very precise and accurate calculation method for alignment of toric IOLs. And these total corneal refractive power values can be directly incorporated into Phaco optics software, which were designed by Thomas Olson for IOL power calculations. So this is the software which incorporates with Pentacam HR, and the total keratometric values can then be used to predict IOL power and the effective lens position. So next formula is the artificial intelligence based formula, Hill radius basis function, or the RBS calculator. So this formula is based on artificial intelligence and regression analysis both. So the regression analysis comes from the very large database of actual post-surgical refractive outcomes to predict the IOL power. And in addition, it also uses pattern recognition to account for some of the undefined factors that cannot be controlled with Vergence or ray tracing equations. Now, there's a certain limitation of this calculator, which is that it basically depends upon the data or the database of the specific types of eyes which are included in the database. So if you have an eye, the anatomic characteristics of this eye, if they don't match with many of the eyes in the database of this software, then the software flags these eyes as out of the bounds, which means that in these eyes, the
1 minute left.
predictability of the accuracy will be less. So with the, this is the how the calculator looks like, and this is continuously evolving. And then we have the Kane formula, and the Kane formula, this is based on the theoretical optics and incorporates both regression and artificial intelligence components to refine its predictions further. So this formula is available both for toric calculations and non-toric calculations, and also for eyes with keratoconus. Okay, and then we have the LADA super formula. So this formula is basically, it aims at developing a graphical method for displaying IOL calculations in 3 dimensions. So based on the peer-reviewed literature, the most accurate portions of each of the modern IOL formulas were chosen, and an IOL super surface was developed based on the amalgamation of these formulas. And from this super surface, the super formula was derived. So this is available on the iolcalculation.com website. And the benefit of this formula is that they are usable, it is usable for all types of eyes, short or long, flat or steep, and different types, different ACD depths. And because of the concept of 3-dimensionality, its depicted super surface serves as a graphical method of computing one or more formulas. And it also takes away the burden and the effort from the surgeon to deal with multiple formulas. So I also wanted to just briefly talk about the total keratometry, which is available in the IOL Master 700, which enables the actual measurement of the posterior corneal surface and does not assume the measurements of the corneal surface. And with this, with the incorporation of total keratometry, 2 new formulae, the Barrett TK Universal 2 and Barrett TK Toric, have evolved. And then there is this last formula, which is the emetropia verifying optical, or EVO formula. This is based on the theory of emetropization, and it generates the emetropia factor. And based on this, what they say is that because the cornea growth is mainly completed at infancy, the majority of the eye growth occurs in the posterior segment. So for a specific corneal power, there is a specific axial length and effective lens position to achieve emetropia. This is also a thick lens formula, and it can handle different IOL geometry and powers. So this is available at the evocalculator.com, and also a toric version is available. So to conclude, with continued deployment of advanced mathematical techniques, artificial intelligence, precise biometric instruments, and introduction of additional variables, the IOL calculations have now improved significantly, and they still have potential to reach new heights of accuracy and simplicity. Thank you so much for your kind attention.
Thank you, Dr. Sheetal, for a very complete overview of the different IOL formulae and the essential principles involved. There are going to be some questions here, and I would want my expert panel also to be involved. So, Sheetal, the question is directed to you, but it's thrown open to the others. What would you say? Now, we believe that Barrett's has become the mantra for all kind of scenarios, but what would you advise as the different alternatives or the best formulae for extremes of axial length for short eyes and long eyes?
So I think those clinicians who have access to IOL Master and LensStar, they also have access to say formula like Olsen formula. So I just described that Olsen formula works over, it is independent of axial length, and it works over the whole range of axial length. So if you have high-end optical biometers, then it makes your job easy, because the measurements of lens thickness and axial length are very, very accurate. So the formula and most of the formulae are incorporated in them, so you can use them easily. Whereas those surgeons who are still using the third generation formulae, and for them, for extreme axial length, I think the Bangkok modification of the third generation formulae is still very useful. And this modification is shown to be at par with the latest generation formulae in terms of accuracy. And for extremely short eyes, I think the Hoffer Q formula is still very, very accurate, and still gives very good results.
Short eyes, I believe that the Barrett's and the Hill RBF would be
also, they are also, yeah, I'm just talking about those who are still not using the Barrett's formula and the more advanced ones. But if they are sticking to third generation formulae, then Hoffer Q for short eyes and SRKT for long eyes.
I know. You believe that they still have a role to play? SRKT.
So basically, yeah, this is for those who are not still using Barrett's formulae and the most modern formulae. But SRKT formula and the third generation formulae, even if the surgeons optimize their constants, A constants further, they can still get very good results. I think it's all about the measurements, the accurate measurements, and optimization of the A constants.
Dr. Ramurthy, did you want to add? Dr. Ramurthy? Dr. Sri Ganesh?
Yeah, I think now most of the formulas are available on website. So see, basically for the postgraduates, when you start off your practice, you may not have access to very high-end devices like the LensStar or the IOL Master 700, but then you can see that the Barrett's formula especially is available on the APACRS website, AACRS website. So you can easily access this. And in our practice, we are using the Barrett suite on the IOL Master 700, and it works very well. The Universal 2 and the Universal 2 Toric is excellent for all axial lengths. And we find that in almost 95% of our cases were within half a diopter spherical equivalent. Of course, if you have post-refractive surgery, then you have to be careful, and then you will have to have special formulae for this. I think the future to come will be ray tracing, because with ray tracing, you are not exactly dependent on the axial length and you can, or the keratometry, but you are measuring the optics as it is. And we are using this now, and we're doing a comparative study. We have the MS39, which basically is a high-end, high-resolution OCT, which maps all the surfaces and then looks at the individual optical surfaces. And then also it takes into consideration the abrasions. If you just take the K readings, suppose the cornea is abrated, you have a high spherical abrasion, then what happens is, again, your IOL calculation may not be accurate in the normal formulas. But what happens with ray tracing is it takes the complete optics of the surfaces and then calculates according to this. And what we have seen is, even we are doing a study on post-refractive surgery eyes, because these are the very challenging eyes, even post-RK or post-LASIK corneas, where you can have a lot of abrasions. And then hitting the target in these eyes is very difficult. And we have seen that what works well is the Barrett True K, which is emerged as the formula for post-refractive, but even there's a TK True K, which is even better if you have the IOL Master 700, but the ray tracing optics are very close. The difference between the two is less than 0.5, and then we're studying this. And the advantage of ray tracing is you can actually show the patient on a simulated Snellen's chart as to what is the kind of vision. Say, suppose you put in a toric, what is going to be the vision, the E-chart, the image, the retinal image. And if you put in a non-toric, then how it's going to be distorted. If you put in a multifocal, what is going to be the vision for distance? What is it going to be the vision for near, including the contrast, you can show them. So this is something that, the patient can actually see visually and then decide. So it will be an excellent counseling tool. So that is what we are awaiting. And I think this is probably the future where you can actually look at the result even beforehand.
It's a very typical postgraduate question I'm asking. Why is the IOL power calculation a challenge in these post-refractive surgery eyes? Anybody?
Yeah, so basically you have the anterior to posterior corneal ratio changes, which is called the Gulstrand ratio. So cornea flattens, and also the refractive index of the cornea, which we always take as 1.337 traditionally. So there is an error because of the change in the refractive index also. So especially in cases of post-RK, where the flattening is very, very, it can be extreme flattening. So in these cases, finding the IOL power can be much more difficult. So in the post-LASIK cases, you can have a hyperopic surprise post-op, and in the post-myopic, you can have a post-myopic cases, you can have a hyperopic surprise, and vice versa for the post-hyperopic. So it's
you have extreme flattening. The problem with the post-refractive is, one is that there is extreme in myopic or hyperopic, there's a change in the center, and the normal curvature is lost. And generally with keratometry, we measure the 3 millimeter, but the relationship between the central cornea and the 3 millimeter, which is assumed in normal formulas, that is lost because you have in post-myopic LASIK, you have extreme flattening of the center. So it does not correspond very well. This is one of the problems. The other is the Gulstrand's ratio is altered. That is the ratio between the anterior and posterior, which can be anywhere between 0.8 to 0.9. This is altered when you have extreme flattening. And most of the formulas use the refractive index in the formula as a compensation for the posterior curvature. So normally we take it as 1.33, though it is 1.37. This is basically to compensate for the posterior curvature. And when this Gulstrand's ratio is altered, again, the and you don't change the refractive index, then you can get the target is off. And then the other aspect is the ELP. Because there's extreme flattening, again, the ELP also changes. The ELP is calculated depending upon the axial length and the keratometry. When there's extreme flattening of the keratometry, again, the ELP is changed. So these are the main factors which can influence. Of course, the abrasions also which are induced. If you have a high spherical abrasion, that also influences the calculation. So there are many factors, and all these have to be taken into consideration when you're calculating for post-refractive surgery.
So one quick question, Dr. Shri. Do you also take into account the spherical aberration of the eye when you choose the IOL, the type of the IOL which you're going to implant?
Yeah, basically for post-refractive surgery, we do the topography, we do the pentacam, and we look at basically the distribution, the EKR distribution. If it's Gaussian, that shows that the ablation is well centered and the cornea is fairly regular. But if it is very irregular, the EKR graph is very irregular, that shows that the distribution of K is irregular. So you can have difficulty in calculating the target emetropia. So, and also you get the corneal abrasions. And if you have a high abrasion, suppose you have a high positive spherical abrasion, then you select a lens with a negative asphericity, like the Technis lens, which is 0.27 minus 0.27. So it compensates for the positive spherical abrasion. Whereas in a high hyperopic correction, where you have a negative spherical abrasion, you do not use a negative aspheric
Negative.
lens. You can use a plano, or you can just use a regular spheric lens with a positive spherical aberration. So this kind of balances out. So it's very important to look at the topography, to look at the spherical aberration, to look at the distribution of the case before you take a decision and about the IOL.
Thank you very much, Dr. Sri Ganesh and Sheetal, for clearing some very essential doubts. I think we could have a session on biometry in one of our future webinars, which would give us a lot more information. Our next speaker is Dr. Harshul Dutt, who will be talking on nucleus management in phacoemulsification. Dr. Harshul is a young, dynamic, versatile cataract surgeon, Chairman Scientific Committee of Rajasthan Ophthalmic Society, and member ARC Central, who has a flair to bring a difference with his abundance of energy and resourcefulness. On to you, Harshul.
Thank you so much, ma'am, for a kind introduction. So I'll be talking about the nucleotomy techniques, and the ideal strategy or the nucleotomy technique. Just a minute. So the ideal technique, it depends on the type of the nucleus which is there. So, but you remember that the technique, any nucleotomy technique which we use, it should be effective, and it should be reproducible in your hands, and it should be safe for endothelium and other ocular structures. And every surgeon over the years developed their own little variation in the technique in which they use. But the prerequisite for a good nucleotomy is a good capsulorhexis, which is of adequate size, should not be too small, and you should do good hydrodissection before you start disassembling the nucleus. So this is the case, which is a soft cataract and has a little PSC there. So I do a hydrodissection, and once I achieve a good hydrodissection and I'm able to rotate the nucleus, as you can see here. So in softer cataract, it's difficult to directly chop the nucleus. So, and as a postgraduate and who is starting their phaco career, I think they should better start with this stop and chop or divide and conquer technique. So here it's on the coaxial illumination mode, and here I'm just sculpting a groove here, rotating the nucleus. Remember that it should be deeper in the center and it should be narrower in the periphery because of the nucleus is thicker in the center. So once you achieve this groove here, you put both the instruments down below at the deeper plane and divide the nucleus in two halves. So this is cracked on this side, and I rotate 180 degree and again divide it into two halves. So once you achieve these two halves clearly, then either, as is a softer cataract, I again make a groove here, as you can see. So your phaco setting has to be very low phaco power, and now you just need to vacuum these pieces out like the piece of cake. And remember that we should always be in the center of the eye and never try to go in the periphery. So that is how you complete this softer cataract. So there may be a situation that the cataract is so soft that you're not able to even trench in the nucleus, and as you typically see in pediatric cataract or the cataract like this. So again, I make a capsulorhexis, do a good hydrodissection, see this wave traverse all across the equator. And then it's important that you go ahead and do the hydrodelineation so that you separate this endonuclear core also. Here again, the settings are that I use very minimal phaco power of just 2 to 3% phaco power. Basically, you just need the vacuum here to take care of this very soft nucleus. So there are various techniques like chip and flip or the salute technique or different kind of techniques which I use. So essentially, remember that you just may increase the vacuum and you just take out this softer nucleus which is there. So it completes the case. Now, once you master the stop and chop and divide and conquer technique, now you come to the phaco chop technique. So this is a white cataract taken here. So once you have a good capsulorhexis, now for this is the vertical chop, you go ahead and engage the phaco probe in the center of the nucleus And now see the chopper goes vertically down in front of the phaco tip, and you just literally separate phaco tip and the chopper. So it is basically your left hand which is working more. Your phaco probe is just, stabilizing the nucleus and making a good hold on the nucleus so that you can effectively chop the nucleus into pieces. So either you can do the multiple chops first and take out the pieces one by one, or you can take out one or two pieces and complete nucleotomy. In these cases, always remember that you bring these pieces in the pupillary plane, as there is no cortical cushion to support the posterior capsule. And you should not have any surge also in your machine, because that is very can be very devastating, and it can cause the posterior capsule rupture if the PC comes in your phaco probe. So this is the last piece which comes off. So that was the direct vertical phaco chop. Now come to a case where we have a brown and black cataract like this. So this is in these type of harder cataract, which have a very thick endonuclear core and very thick posterior plate, fibrous plate. I use the technique which I described in 2010 in European Congress in Paris. That is what I call drill and chop technique. So it is very advantageous in cases which are brown and black. See, what I'm doing here is I'm drilling in the center of the nucleus deeper. So I'm very well away from the capsular axis margin. So once I drill like this in the center, the advantage which I get is that I weaken the central endonuclear core. I'm rotating the nucleus with my chopper and drilling in the center deeper down. So once I've drilled enough, now I go and I can place my phaco tip deeper in this drill which I made, and I'm very well away from the capsular axis margin. So this is the normal chopper which I'm using. So I go ahead and use this chopper to split nucleus. Now you see this whole crack, it goes from anterior to posterior side. So I rotate the nucleus 180 degree. You see, I can see the split there. Rotate 180 degree, hold it from one side, and complete this crack. So now what we want is these nucleus to be divided in these two pieces. So once you have divided the nucleus like this, you go ahead and make further smaller pieces. So your chopper in your left hand is the key instrument which cracks and split the nucleus. And you can see the splitting action, and you can take these pieces one by one. So that's the way you should deal with the brown and black cataracts. So this is again the modification of the vertical chop, what I call a drill and chop technique. Let's see one more case which has brown and brown cataract. But the difference here is, of course, it's a brown cataract, but there's a lot of cortical matter which is there. And once this cortical matter comes off, there's a lot of space which is created between this nucleus and the capsular bag. See, it's very much mobile in the capsular bag. So for these type of cataract, what I do is I just try to give the horizontal chop. See, I've drilled in the center. I stabilize the nucleus. See, it's very much mobile in the capsular bag. I lift it up and get the chopper from the equator. This is what is the horizontal chop. Ideally, you should use a finger-shaped instrument which is very blunt, but this chopper will also do. So you can use this technique. So you need to master various techniques so that you can use the combination of these techniques to tackle different type of nucleus. See again, so this finishes this case. This is the Morganian cataract again. So once I achieve capsular axis, see this is a very mobile nucleus. So the trick here is to go with the bevel down. So once I go with bevel down, I stabilize the nucleus, and again getting my chopper from the equator here, and that splits the nucleus. So you just go with bevel down, lift slightly nucleus up, stabilize it, and use your chopper to split it. So last case, another Morganian cataract. See, again, I go with the bevel down. You see, it's very difficult to stabilize these nucleus because there is no cushion there. So you need to be very meticulous in chopping them. So I think we all need to learn all these different kind of nucleotomy techniques, which can come, which we can use in various combinations in different kind of cases. Thank you very much.
Thank you very much, Dr. Harshul, for showing different types of nucleus management and with your own inputs about it. There are 2-3 questions which are here.
Yes, ma'am.
Dr. Mahipal connected? Dr. Mahipal is not there?
No, he's
not connected. Okay, Namrata, could you just briefly tell us about the power modulations which you would advise for some of these types of different types of cataract? And just a gross impression as to, for the postgraduates to understand how you could play around with the ultrasound and the vacuum and aspiration.
I think Harshul, very excellent talk, and I've heard this in the previous session. It just demonstrates everything very nicely. And regarding the power modulation, I think you have to go by the grade of the cataract. So if the grade of the cataract is soft, then obviously all your parameters will be on the lower side, because you would have, already, you don't want cheese wiring happening in a soft cataract. Vis-a-vis a hard cataract. If it's a hard cataract, then you would probably make a crater if you're a surgeon who's beginning. So when making a crater at that point in time, you don't want you don't want too much of you would first make a crater and then you would chop. And again, for a very hard cataract, you can resort to, if you have a machine like Centurion, then probably apart from Ozil or apart from Ozil, you would also want some amount of Phaco there, because the hard cataract will not break. So for cataracts which are soft, all your parameters would be on the lower side, whether it is the flow rate or it is the vacuum, because you don't want everything coming in too fast. But if it is a hard cataract, then your flow rate would be on the higher side, because you want everything to come up to the Phaco probe, and your vacuum also has to be higher, because you have to purchase onto the edge of the crater or for chopping. So at that point in time, your vacuum would go higher, but as you make the crater, your vacuum will not be high. It is going to be on the lower side, especially if you're doing in divide and conquer technique, then you have to make the crater, so you cannot have the vacuum too high. You have to keep modulating, and like for instance, if you come to the epinucleus, then again some machines would have a epinucleus mode, but if they don't have, again all your parameters would go down, the flow rate, the vacuum. And when you come to the last piece again, because that last piece is wobbling around in the whole of the capsular bag, so again your parameters have to be on the lower side. You can control it with the foot pedal itself to again make your vacuum a little lower. The flow rate has to be lower, because you don't want everything sucking in. So in the various stages of the cataract, and depending on the hardness of the cataract, the modulation of the echo, the flow rate, the vacuum, all will have to occur. And in some of the machines, intraocular pressure also plays an important role, like in Centurion. So you increase the IOP, make it higher so that there is no surge there. Some of them, it will not be there. And likewise, decrease the IOP in some of the cases, like special situations. For instance, we have a post-VR surgery.
Thank you very much for a very detailed explanation, Dr. Namrata. Dr. Sri Ganesh, just a word.
I think, in very soft cataracts, very hard cataracts, most of the postgraduates and residents, the problem is they don't sculpt deep enough. So very soft cataracts, very hard cataracts, you have to have a deep trench. Otherwise, you cannot crack it, because soft cataracts, you will cheese wire. And you will not be able to crack it unless you shave the posterior plate and it's very thin, then you can crack it. Otherwise, it's cheese wires. In very hard cataracts, you have very leathery fibers. So unless you sculpt deep, you will not be able to split the epinuclear plate. So in very hard, very soft cataracts, you have to sculpt deep enough. And usually you're not able to crack because you're not sculpted deep enough. That is one aspect which I wanted to address. The other thing is that sometimes the most difficult cataract are those cataracts which are, I think Ronyo calls it neither here nor there cataracts, because you can't really split it because it's cheese wires. You cannot crack it, and it's not soft enough to be removed with a high flow rate and vacuum. And these are cataracts where I do what is called a mechanical chop, and there are other techniques described. You can also do a cartwheel or a carousel technique. And the other very nice video with Ron showed recently was what is called cross chop, where you're taking your chopper through the side port across the Phaco probe, using the Phaco probe as a support in the groove, and then chopping it at 90 degrees. So this also works well. And these are various techniques. What is very important is to learn about the Phaco dynamics and how you can use a machine, and in which cases you should use a higher flow rate. For the very soft cataracts, I like to use a high flow rate so that the whole thing comes out into the antechamber, and then you can remove it, because most of them are beginners are afraid of using higher flow rates because they think it's not safe. But in good machines where you have surge protection, using a higher flow rate for soft cataracts makes it faster and easier to evacuate the nucleus. So these are just a few points. And power modulation, of course, it varies from machine to machine. You have a lot of new software, like you have the Ozil in the Centurion, you have different types of tips in the Signature, you have the white star, and you have variable white star, which you can use for hard cataracts, cold Phaco to reduce the incidence of wound burn and total Phaco energy to be used. So you have to know your machine very well, and then you can decide on your technique.
Excellent presentation, Harshul, and I think almost everything that needs to be said has been said. Just a couple of brief points I want to make is one is your drill and chop technique. I think the basic premise in that is that you have to have a deep groove in this hard cataract so that you get a purchase onto the meat of the nucleus. Yes. So there are various techniques. You could just make a groove there, but that's the basic principle in the sense that unless you are able to bury your Phaco tip into the meat of the nucleus, you're not able to chop it adequately. And basically, the Phaco tip remains constant. It's only the chopper which is moving. And this is one way of doing it. The second point I wanted to make was when you have a Morganian cataract and like what he showed in his last video, a nucleus spinning around or the last fragment, and sometimes in these hypermature cataracts, the capsule is also very fragile and there's a constant tendency for it to trample in. In these cases, it's also even a good idea to put in an intraocular lens inside, but that itself acts as a tamponade protecting the posterior capsule, and then go ahead and Phaco it. I mean, it might appear for the early beginners, it might appear as if the space will be significantly constrained, but it offers a significant protection and are able to do it in a more controlled manner.
Thank you. Shall we go on to the next speaker? Harshul, do you have any?
Yes. No.
Okay.
Yes, good. So now move on to the next speaker. We have Dr. Vaishali Vasavda from Jaipur and Ahmedabad. And she's a versatile surgeon, a great academician, and she has to her credit numerous national and international awards. And she'll be speaking today on astigmatism management in cataract surgery. Dr. Vaishali.
Thank you so much, Chitra Madam. Thank you, Harshul Bhai, and everybody on the panel for having me in this wonderful session. Without much ado, I'll get to my topic. And I think it is very important, especially when you are laying the foundations of your practice or your cataract surgery, which is going to be the bread and butter for any super specialist also, to understand how astigmatism affects the outcomes of a cataract surgery and how we should be basically paying attention to astigmatism right from the very beginning of our training. So the whole premise of this presentation is that what happens if you don't worry about astigmatism or if you don't treat it? It's not like you are not going to rehabilitate the patient. They will get from, if somebody was partially blind, they will be seeing well. But the whole idea is to give them good quality vision. especially now that we are dealing with refractive cataract surgery. And astigmatism, which was originally described because it's a PG talk, basically it's in refractive error, where there is a difference in the value of magnitude and the axis of astigmatism, meaning one axis is typically steeper than the other axis. And I think there have been many studies globally, but the whole crux of all the literature is that we have at least 30 to 40% patients of our own cataract patients who will have treatable astigmatism. Now, as of, let's say, 5 years back, anything more than 1 or 1.5 diopter was considered treatable. If we go by today's definition, which is 0.5 and more, I think almost 70 to 80% of our cataract patients would require some form of astigmatism management. For example, let's take a patient who has a grade 3+ cataract and has some myopia along with some astigmatism. So this is a patient who basically needs addressing 3 problems: the cataract for clearing the path of vision, treating the myopia by putting, like Dr. Sheetal very nicely described, how you do an accurate calculation and put in the right IOL, and then treating the astigmatism, which will give good quality of vision, even for near vision. Most often people say that if you treat the astigmatism, you will have good distance vision, and near vision, you still need glasses with a monofocal lens. But I think the quality of vision, even for near vision, will improve a lot when you treat astigmatism. So we must realize that we are doing a 3-pronged approach during cataract surgery by treating each of these entities. And this is data from our own clinic, where we found that more than about 70% patients have at least half a diopter or more of astigmatism. But does it matter, or what degree of it matters? Now, in this study, we compared eyes with 0.5 or 0.25 refractive astigmatism, means in their glasses, or 0.75 and 1 diopter. And we looked at their contrast sensitivity and their reading vision, the speed at which they could read words. And both of these were better when you had a lower cylinder, even if you were to wear the glasses. And I think a lot of us who ourselves have used astigmatic glasses or are using currently can vouch for it, that if even with the glasses, sometimes the clarity may not be as much as compared to somebody who does not have any astigmatism. So the whole point is that anything that you end up with after surgery, if it is more than half a diopter, it is going to affect the vision of your patient. What at the outset we need to understand as cataract surgeons, that although the final outcome we measure is refraction, how much can you see and what is your refractive cylinder, but what we can only treat today in cataract surgery is corneal astigmatism. Maybe with ray tracing corneal treatments, which is a different refractive surgery, you could also deal with certain other forms. But as cataract surgeons, we have to look at the cornea and treat the cornea, and therefore know about the cornea. So the one of the most important factors, especially when you're beginning and when you're doing multiple types of surgeries, like was discussed with Dr. Harshul's presentation, not all residents or fresh post-PGs would be doing a Phaco for all their cases. So you need to understand that with whatever kind of surgery you are doing, depending on the size and location of the incision, what was the pre-existing that you measured on the cornea? What are you going to add to that by your own surgery? And therefore, what is the surgically induced astigmatism? And we all were made to understand initially, when the clear corneal incisions came, that any incision less than 3 millimeter is supposed to be astigmatically neutral. But subsequently, we now know that that is not true. Any cut that you make and which heals, because collagen heals and it causes subclinical fibrosis also, is going to result in some astigmatism, however small or large it may be. So it's a good idea to know about your own astigmatism. What affects it? Location. So a scleral incision or a posterior limbal incision will cause much less astigmatism as compared to a clear corneal. So in the beginning, I would suggest, especially when you're starting with Phaco, you might be causing wound burns and all. Don't go very corneal. Try to stay at the posterior edge of the limbus. The type of size and the integrity. So if you see here a scleral incision, and for those of you who do SICS or even with Phaco, there's no shame or nothing wrong with a scleral incision. In fact, sometimes if a corneal incision is badly done, it might lead to more astigmatism. A frown versus a smile, a frown will give less astigmatism. So the type and location of the incision. Now, superior and temporal. People do say that superior incision may induce sometimes less astigmatism, or in my hands, temporal. But I think the basic thing is also your comfort. With deep brows and early learners, not the best of machines, not the best of cooperation of patients, sometimes it is always a good idea to do a temporal incision, because then at least you know how much you are inducing and you are comfortable in your zone. A smaller incision obviously will induce lesser astigmatism as compared to a 3.2 or something more than that. What is very important for us to understand is that it's not a game of numbers, that 1.8, 2, 2.2 millimeter, what is my mix or S mix incision. It is what integrity you are going to leave behind. Like if you are going to cause this kind of a wound burn, however small your incision was, it's all down the drain. It's going to cause a lot of astigmatism. Incision like this, you have to suture it, and obviously it's going to change or increase your astigmatism. So an ideal incision, as you can see here, is something that is almost square, has a decent length comparable to the width, and is not altered by heat or by mechanical injury. Even side ports, as you can see this incision here, if they are gaping and if they are wide, they can heal irregularly and cause some astigmatism because of clinically non-seen stretching of the incision. So make sure that whatever instrumentation you use, no financial interest, should be compatible with your incision. So if you are using a hydrophilic IOL, going through a 2.2 may be a challenge. At least I always find that it's always better to enlarge the incision a shade more, because then you are not stretching it so much while implanting, and therefore you will induce lesser astigmatism. How do you calculate? We must understand that 41 and 42 keratometry does not mean 42 minus 41 one diopter, because the astigmatism is a vector quantity, it has a direction and it has a magnitude. Now, we really don't even need to go into the mathematics of it today. All we need as surgeons is pre and post-op keratometry and the axis at which your incision was placed. Take 30 cases which you have done with the same kind of knife, because as junior surgeons, every time you may have a different sample or a different knife. So try to have the similar kind of knife, the same size, location and technique. And there is a range of softwares, even a lot of our own Indian softwares are there, which are available, some on the Aios website, some otherwise, and can calculate the surgically induced astigmatism. Dr. Warren Hill has this excellent website, siacalculator.com. But roughly speaking, after a certain degree of experience, with a 2.2 or a 2.4 millimeter incision, you typically don't induce more than 0.2 or 0.3 millimeters if you're doing a temporal incision. Also, we need to understand that when we talk of total corneal astigmatism, posterior corneal astigmatism is also important. You may not, and you don't need to measure it in every case. So I just want to pass the message for everybody that if you don't have a pentacam or any Scheimpflug or OCT device, which most people will not have in their early practices, you are not going to be an inferior surgeon, or your outcomes are also not going to be inferior. Just keep in mind that 10% eyes will have some variation in the posterior astigmatism. And the most important thing is, how do you evaluate this astigmatism? I think what we miss out many times in our training is that you look at the eye to be operated. Always focus also on the other eye, which may be phakic, or which may even be pseudophakic but has a residual cylinder. So look at the unaided vision, the spectacle correction, and look at the keratometry of both eyes. Now, the manual keratometry, which all of us have access to at some or the other level, is still a very good means of measuring the cornea. If you have all these more advanced automated instrumentation like optical, topography, Scheimpflug, that is the icing on the cake. But it doesn't really have to be there. You can still do very good surgeries. You can do torics, multifocals, even with a good anterior corneal curvature measurement. What mars astigmatism measurement typically is the dry eyes, which go undetected and which cause a distortion of the Myers. A lot of the dry eyes induced by us in our clinic, putting in drops, by doing applanation IOP, dilating the patient before they go for their pre-op or their biometry or keratometry. And therefore, my request to all surgeons would be that if you measure keratometry, either do it as the first thing before putting any drop. Now, if you have put in drops, no problem. Make the patient wait, put in couple of times lubricating eye drops, and then do it so that you don't get a wrong reading. And a skill that everybody should acquire in their residency while you still have access, you can do it on your own selves, colleagues or staff members, is how to measure the manual keratometry yourself. Because when you start off your practice, you may not have the best trained technicians and optometrists whom you can rely on. So you have to be on top of it at some point. Like the point of showing this picture is that we all need to be very precise and thorough in our basic measurements, especially when we are beginning, for our own confidence, for the patient's confidence in us. And then obviously you move on to better instrumentation as you evolve. As a rule, general rule, posterior corneal astigmatism is always horizontal and it doesn't change throughout your life. And it is about 0.2 to 0.3 degree, which is a good thing to know. What we do need to understand as surgeons is, like I said, we can only treat the cornea and we can only treat the astigmatism on the cornea, which is regular. So if it has two axes which are at 90 degrees to each other and which would look like this on a topography, only then can you actually do something for the astigmatism. If you have an astigmatism which is something like this, you don't have two clearly defined axes, then you will not be able to successfully treat this only with your cataract surgery or the tools that you use. So that is one thing we also need to understand, that if it is an irregular astigmatism, a pterygium or a corneal degeneration, you need to tell the patient that this is something we cannot address just with a cataract surgery alone. Now, what are the options? Incisions, lasers, glasses, contact lenses, toric lenses, and all are very good. It all depends on your experience, the kind of setup you have and access you have. But I think incisions now, unless you have the femtosecond or you're really a master of incisional surgery, which I doubt most of us would be when we start our practice, may not be very predictable. They tend to regress and they are not a very long-term solution. So, but yes, if you have up to 1 or 1.5 diopter, please go ahead, nothing wrong with that. But alongside also manage the ocular surface by giving them lubricants. So that is my only concern with incisions. Lasers, yes, they are very good and they're extremely precise. But again, with beginner surgeons, who is going to pay for it? You may not have access to it in your own facility. And the patient may not agree for a second procedure. So if it does work for you, bioptics, that means lasers to treat, is an excellent option. And then obviously glasses or contact lenses, which needs a lot of counseling. 2 or 3 times you have to call the patient and be nice to them, listen to them, because they think you are a junior surgeon and you did something. So just be nice to them, listen to them and tell them that, yeah, you may need glasses. It's not the end of the world and sometimes this happens. And then the toric lenses, which have actually really changed the way people manage astigmatism with cataract surgery, no financial interest. And they have been now tested for almost 20 years now. Why I like toric IOLs personally? Because they're a part of my routine cataract surgery. I don't need to have any extra procedure or sort of manipulations. And there is no regression. There is no additional harm that I do usually by doing a toric IOL well. But obviously, whatever toric IOL you choose, now there are many companies available. They should be rotationally stable and they should have a good PCO profile. Because if you do a good surgery and you develop PCO within 6 months, your patient is not going to be happy to get a YAG capsulotomy so early, and because his vision is going to be blurred. All toric IOLs have different spherocylinder combinations. That's the basic optics. And this is just some of the international marketed toric IOLs. And this shows that basically what this shows is that all of them are very stable nowadays. They are very rotationally stable. And these studies have also shown that.
Thanks.
Thank you. I think my whole message was that be aware of astigmatism, please. And right from your suturing of ECC days, start taking a note of what you induce, maintain a logbook, and that will go a long way in helping you in the future. Thank you.
Thank you, Dr. Vaishali. That was a lot of information for the youngsters and all of us along the way. But nowadays we do talk about these Toric IOL calculators. What are those features which are incorporated in them, which makes our IOL power calculation that much more precise?
Thank you, ma'am, for that very relevant question. And I think the best part about Toric IOLs is that now we have the free online calculators. One, every brand has their own calculator, and the company representatives are more than happy to help you. But even the Barrett Toric calculator, which is freely available for everybody, it incorporates an automated adjustment of the posterior cornea. And therefore, the ELP and the estimated astigmatism, the IOL model needed, will be very accurate. So all you need to do is enter your steep K, flat K, the axis, the spherical power that you calculated, and what target you are aiming at. And then the calculator automatically gives you the model, which model, how much astigmatism it will correct, where to be placed, the axis of placement, and what you should expect. And I think every brand has them, but I would still very much rely, like Madam also said, Chitra Madam, that the Barrett formulae of all kinds are excellent and they are free. So you don't need any fancy equipment. Just go on your computer and calculate it and you'll be bang on.
I think every IOL manufacturer has his online calculator now. Previously, they were not having PCA, postercorneal astigmatism, but now many of them have included PCA, postercorneal astigmatism. But normally when you use this online calculator and also check with the Barretts, there is a little bit of difference. The reason is because many of these formulas do not include ELP, effective lens position. Now in a toric, if the lens ELP is not taken into account, then you can have a difference in the toricity. So Barrett's formula takes in not only the PCA, but also the ELP, and that's why it's better, and that's why we prefer to use it. But we always do both the manufacturer's online calculation and the Barrett, and then check both, and then select the lens.
I think Vaishali made several excellent points. Just to re-emphasize, one is the fact that, I was sticking on to a 2.2 millimeter incision for a long time, but almost a year back, I shifted over to a 2.4 millimeter incision. And previously, about 3-4 years back, there used to be a lot of noise about the size of the incision. We thought sub 2 millimeter is great. Now, as very eloquently brought out by her, making an adequate incision which you do not stretch or burn is extremely important. As far as this clean cut, it is fine. I slightly differ from her as far as the surgically induced astigmatism concept is concerned, in the sense that we used to use that Warren Hill website and calculate our surgically induced astigmatism. I used to believe that my 2.2 millimeter incision is inducing a 0.4 diopter of astigmatism. I used to feed that in. But today, with the concept of centroid value coming in, as she mentioned, we know that astigmatism has both a magnitude as well as a direction. So Douglas Koch and Warren Hill, etc., have shown that for a sub 2.4 millimeter incision, clear corneal incision, the astigmatism centroid value is just about 0.1 diopter. So you may not be going very wrong even if you just ignore the astigmatism induced by your clear corneal sub 2.4 millimeter incision. But of course, if you're doing a SICS incision or a superior 3.2 millimeter incision, things might change. So essentially, the emphasis on surgically induced astigmatism for a temporal clear corneal incision has somewhat gone down. The other factor I would like to emphasize is that, please make a distinction between a with the rule astigmatism and against the rule astigmatism, because as she mentioned, against the posterior cornea also has mostly against the rule astigmatism. So that's the reason that even for about a 0.75 diopters of astigmatism, I would go ahead and consider, again, against the rule, I would consider a toric IOL. But if it's with the rule, especially if it's a young patient, even up to about 1.25 diopters is okay. And again, it's not an irregular astigmatism, but it has to be orthogonal astigmatism, it has to be corrected. And even you have to understand all these concepts, but as was mentioned by both by Vaishali and by Sri, most of the present day calculators incorporate a compensation for the posterior corneal astigmatism, and they also have this toricity ratio where the ELP is taken into consideration. So it might be Barrett, it may be Holiday too. So these correction factors are incorporated in the formula. Even the Indian manufacturers do that, most of them. So once you have that, and if you give reliable data to them, you won't be doing much wrong by going ahead and implanting the lens that they calculate and tell you. Of course, the acquisition of data that you do has to be reliable, whether it is by way of optical biometer or immersion biometry. But if the data is good, most often the calculations are quite reliable.
So if
One
we
more
are
point which I want to tell the postgraduates, of course, Dr. Vaishali spoke about it also, is to assess the ocular surface. And many of these older patients have pterygia. So if there is a pterygium which is present, don't go ahead and do a toric IOL calculation. First, remove the pterygium. Then the astigmatism settles. You wait for a couple of months, a month or two, until the keratometry is stable before you calculate a toric IOL. So that is something which they should not ignore.
I think we need to take questions which have come on the web portal, ma'am.
Yes.
So there's a question from Dr. Kamal Kishore Vaishali. He wants to know that many patients have uncorrected astigmatism throughout their lives. So will correcting the astigmatism will create problem in the adaptation?
That's a very excellent question, Dr. Harshul. And there's a lot of debate. In fact, a lot of surgeons say that you should leave behind some against the rule astigmatism because it increases your depth of focus. But this is, I think, if you speak from purely optics point of view, correcting any astigmatism, even however small it is, gives you excellent quality of vision, especially unaided vision for distance. And even when you put on your near addition, if it is a monofocal IOL, or a multifocal even more, it enhances the quality of vision. But then the other factor is, like was mentioned by Dr. Sri Ganesh sir also, that astigmatism which we measure as refractive is sometimes some kind of aberrations on the cornea which cannot be measured by sphere cylinder refraction, manifest as a cylinder. So many people are used to those kind of spherical aberrations which may manifest as a refractive cylinder and give them a little depth of focus. So somebody who has always used a moderate cylinder, let's say 0.5, 0.75, may tolerate it. But somebody who has never worn an astigmatic correction, because the lens compensates for a lot of that, will never be able to tolerate. So my philosophy, which has changed over time, is that I really don't know who will adjust and who will not. So I would rather correct all the astigmatism and at least give them one good unaided vision distance.
This is what Jack Holliday had a very nice paper on this, that if you have against the rule astigmatism of about 1.5 diopters and you have a small pupil, then most of these patients are able to read. Uncorrected vision also is good, but the distance vision is not great. And the MTF basically reduces with astigmatism. So this is very important. If you want to have a very high quality of vision, then you have to correct the astigmatism. And this is something that we should aim for in modern day cataract surgery. Post-op astigmatism is a stigma against the cataract surgeon. So if I see a patient with post-op astigmatism, then the surgeon is not good enough because he has not addressed it.
And one
He's
question,
not a refractive cataract surgeon.
Question for younger ophthalmologists who might be watching. Till how late can you rotate a toric IOL if there is malposition?
Ma'am, that again depends on the kind of IOL also that has been used and your surgical experience. But if you, in most cases, up to 2 or 3 months, you can rotate. But the ideal time would be within 2 to 3 weeks, because after that, the anterior capsule fibrosis sets in. And then creating that plane, especially like you said, for younger surgeons, going in a second time, opening that plane and rotating itself is a big challenge. So I would suggest that all patients should be seen by 2 weeks time, toric or non-toric, and especially toric, because if you have to rotate, you should do it within the first month, ideally. But yes, up to 2, we have done up to 3 months latest.
Again, interesting question is, when do you rotate malposition toric IOL? So this is a big debate. Many of them, first day they see that the axis is off and the patient has some astigmatism, and immediately they take them to the OT. Please don't do it, because the first day refraction which you do is not accurate for the cylinder and the axis because of the corneal edema. It has to settle down. Plus, the bag is not sticky. So even if you rotate it, sometimes it re-rotates. So I typically like to wait for at least 2 weeks. And I like to rotate the lens after 2 weeks, because by then the bag is a little sticky. So even if when you put it in the new position in the correct axis, then the chances of rotation are less. And by the time your corneal wound also has settled down, the edema has settled down, so you can get a accurate refraction, and I use the Zaldivar caliper on the eye trace, and this is an excellent device which shows you how much to rotate. There are also many formulas on the internet which you can use. In fact, Alpines has one where you can put in all the data and the lens details, and it shows you how much you should rotate.
Maipal sir wanted to add something, I
Yes,
guess.
Dr. Maipal.
Maipal sir?
Basically, Shri, I agree with you, but the assessment of the placement of the IOL should be done ASAP, in the sense that if on the first day you are not getting a good vision, I 110% agree with you that there could be the corneal edema, which could vitiate the readings of what you are getting, say, on an AR or what it is. But normally, if there is a vision which is subnormal, that means that you expect a 6/6 and the cornea otherwise is clear, and etc., and you are getting an unaided vision of, say, 6/12, 6/18 or whatever, plus you are getting a plus and a minus in the auto ref. Under those circumstances, I would dilate the patient and would go back with the charts and see as the charts
You
are.
can always check, but the ideal time to rotate is
Let me
2 weeks.
let me complete. So all that I am trying to say is that the patient should be at that particular time told that there could be a need for redialing, rather than telling the patient at 2 to 3 weeks, because then the patient, at times at least I have had an issue where the patient kind of gets a little upset. So it's better to tell the patient that we might want to do a redialing. And the point is that when we have some stability, yes, and the question as to when you can redial, the thing is that if you have missed it out for 2, 3, 6, 8 months, and why should it, until of course there's a history of trauma or something, there shouldn't be any rotation as such. So that means that the surgeon has not been good enough to do a great follow-up, and he or she has missed that there is a rotation that has happened. So ideally, you should never wait till very long, because at times it does get fibrosis, but otherwise it's reasonably all right. For beginners, there may be an issue, but you can actually separate out if there are any fibrosis, etc. There are specific works that are going on for different companies. And the new model, for example, of the Technis, which is come in
Rough edge.
yeah, so that they are much more sticky, where they've modified the haptics. So all the companies are now trying to see that the rotational stability should be there. So actually, when you're looking at an astigmatic correction, first is to assess the astigmatic correction, that needs to be correct. The second is the marking. The person should mark very well, and person should know whether it's whether you are on the digital system or you are doing marking manually. So there, whether you are doing on the slit lamp, the marking has to be very, very accurate, and then the placement has to be fantastic. And then in case there is any problem, ideal is, which a lot of us don't have, is to have an eye trace or something like that, which can actually tell you that even though this was supposed to be the lens position, but because of the whatever is the residual error, how much of rotation is required to get you nearer to emetropia. So that is basically it starts from the pre-op to intra-op to post-op, that you have to really look at to get good thing. And one thing that I have been discussing with companies is that they should actually bring down the prices significantly of low torics, because then it is, as Shri was pointing out, as regards the refractive cataract, if you have 0.75, 1.25, you really don't push the patient to that extent that no, you need a toric. Otherwise, if the pricing is nearer to a monofocal, then you would obviously push the patient that, well, it's like today, if I have an eye hands available with me, I don't even tell the patient between a monofocal and an eye hands, because the cost difference is 2,000-3,000. So I don't even discuss. So if the toric also, the difference becomes much lesser, then it should become a standard of care for even small degrees of astigmatism, as Shri pointed out, that the quality of vision is reasonably, and specifically if you are doing it with a presbyopia correcting lens. If a presbyopia correcting lens has a residual astigmatism, then the patient's deterioration of the vision is pretty significant. So that is much less forgiving than a normal monofocal lenses.
Another point I would like the postgraduates to know is that sometimes you can get a high post-op astigmatism because of lens tilt. So it's not only the wound that causes the post-op astigmatism. Sometimes when inserting the lens, especially beginner surgeons, one haptic is in the bag and one haptic is in the sulcus, especially if they have difficulty, the pupil comes down while inserting the lens. And then you have a lens tilt, and this can give rise to astigmatism. So with the eye trace, you can, of course, on slit lamp examination, dilated slit lamp examination, you should watch for this. But the eye trace also will show high internal aberrations, especially coma. A high internal coma is one of the indications that the lens is tilted or not centered well. And this is also has to be taken into account.
And in case of a tilt, I don't think we'll want to wait for 2 weeks, right, Shiri?
Yeah.
I
Can I add a point?
I really don't know if the PGs are understanding what eye trace is. If they are, or if they are, you know.
Can I say a point which PGs might understand?
Yes.
Yeah. So when you read the astigmatism, the toric calculation chart, often you will see that there is the axis of alignment and there's the axis of residual astigmatism. Please don't mix up those. I have myself mixed up, and you'll end up in an off axis. So it's very, I mean, in your hurry or anxiety, especially if you are early into this, you might, the axis of residual astigmatism is often away from your planned alignment. So you need to be very careful while choosing your axis.
Just one practical point I want to make is that, there was a significant Japanese study which was recently published about a year back, which showed that when these toric lenses were serially followed up, irrespective of the type of lens, from 1 hour post-surgery to 6 months post-surgery, 80% of the rotation of these toric intraocular lenses to malalignment occurred within the first 1 hour. Yes. And only rest of the time, 1 day, 3 months, 6 months, they had multiple times they had looked at the alignment. So most of the misalignments happens within the first 1 hour. Most of us do surgery under topical anesthesia. We don't patch our eyes. We actually celebrate our surgery by saying you can jump around, etc. Actually, very recently, I've changed the concept that my toric IOLs have started patching them immediately post-surgery, ask them to rest in the ward for about a couple of hours, then see them and send them off. And there are others who also agree with this concept that it's better to ask your toric patients to take it easy, at least on the day of the surgery, and not to involve in too much of physical activity. Maybe that might promote better alignment of the lenses.
That's a very good point, Ram, because I think David Chang also had a study where he showed that, within the first couple of hours, there's maximum rotation of the lens, all those lenses that rotate. So ideally, you should not even be making the patient sit up. You should wheel them out and let them be lying down for 1 or 2 hours before they are discharged. And what I like to do is I like to inject the lenses under BSS. I don't use viscoelastic, and I keep the IOP slightly on the lower side, because if you increase the IOP quite a bit, the bag expands. Or if you leave behind viscoelastic, then there's an increase in the IOP immediate post-op, and then the bag expands. So the bag expands, especially in high myopes with larger bags, then the incidence of rotation is high. So if the bag has collapsed and then you wait for some time and then you discharge them after 2-3 hours, then the stability is much better.
And Shiri, in this particular, one second, Shiri, in this particular case, if at the time of discharge you find that there is a rotation, I would not allow the patient to go home. I'll redial at that particular time rather than waiting for this thing, because then.
Thank you very much.
Right.
For your time, I think I should go on to my talk.
No, ma'am. I need to introduce you first. So it's my proud pleasure to invite our ARC chairperson, Dr. Chitra Ramamurthy ma'am, who is, we all know, a charismatic personality. And apart from being a wonderful surgeon and a great orator, she's also a true leader and who believes in leading from front. She's always full of energy and enthusiasm. And under her leadership, we all know ARC is doing great programs and going to reach newer heights. She'll be speaking on management of ectopia lentis. Chitra ma'am.
Yeah. Very good evening to one and all of you. So without delay, I'll try to keep it as simple as possible and relevant. We shall talk on management of ectopia lentis. So essentially, ectopia lentis refers to when the lens is not in its normal position. It could be subluxated or dislocated. It is said to be subluxated when the lens is displaced from its normal position but remains in the pupillary area. and it is said to be subluxated when the lens is completely displaced from the pupillary area. It could be in the anterior chamber or it could be in the vitreous cavity. So again, when we know, once we know whether it's subluxated or dislocated, we need to very briefly know what is the etiology. It could be something as common as trauma, which is of course a non-progressive type and quite a common occurrence. It could be iatrogenic, which is surgically induced. It could be part of the primary ocular disorders which are associated with the ectopia lentis. It could be part of a hereditary status where there are no systemic manifestations. It could be part of some systemic conditions which are quite common with or associated with ectopia lentis, or some systemic diseases which are rarely associated with ectopia lentis. So trauma is the most common, as I had earlier said, and that good news here is essentially the pathophysiology is not for a progression, and these could be better managed based, of course, on the extent of dialysis. And next is the iatrogenic ectasia, which I would show you a video later on, which could again be managed based on the amount of dialysis which has been induced during the surgery. The primary ocular disorders which are associated, it could be something as common as a hypermature cataract, a pseudo-exfoliation syndrome, ophthalmos, or a high myopia or more, or retinitis pigmentosa even. It could be part of the hereditary condition wherein there's a defect in the neuroectodermal tissue. So you might find that the lenticular ectopia and the pupillary ectopia are actually in opposite directions, so quite a rare scenario. It could be some of the common systemic conditions which are associated with ectopia lentis, like in Marfan's, homocystinuria, Weil-Marcesani, and others. And we need to know a little more about some of these syndromes, like Marfan syndrome. It's bilateral and symmetrical, and commonly it is a superotemporal subluxation, and you will find that the zonules are stretched here, not matted, and they are unbroken. And progression of subluxation is quite common here. And this is an autosomal dominant status, which could have some angle anomaly with glaucoma, could have retinal detachment, could have some ocular abnormalities, skeletal and cardiac problems need to be looked out for. Homocystinuria is an autosomal recessive, wherein the lens actually subluxates inferiorly. And what is interesting is that the zonules here are matted and broken. It is, again, could be associated with secondary angle closure glaucoma. Patients of this category are taller with elongated limbs. And a major thing to remember here, there's an anesthetic risk in these patients with thromboembolic phenomenon. Again, Weil-Marcesani syndrome could be recessive or dominant. It presents largely as microspherophakia, and the lens usually dislocates into the anterior chamber with a pupillary block glaucoma. And these patients are associated with short stature. And then going on to the next category is the systemic diseases which are rarely associated with ectopia lentis, and there are many of them, which some of them which we may need to refer and keep in mind. So the next thing which we know, now we know about the kind of subluxation and the etiology. What are the symptoms? The symptoms could be based on the subluxation. It could be decreased visual acuity. So it could be astigmatism, which has got incorporated. It could be a myopia, which is pre-existent. It could be a cataract, which is there on a phakic status. It could be a painful eye because of the trauma, or it could be an eye which is in disuse and deviated eye, or a poor near vision because of the loss of accommodation. So it's mandatory that you do a slit lamp evaluation. Look at the cornea, whether it has got some telltale sign of any associated syndrome. Look at the anterior chamber depth. Is it irregular? Which should clue you on to search for any probable iridodonosis or phacodonosis. You could look at the zonules, which might tell its own story. You need to know whether the lens is dislocated anteriorly or posteriorly. You need to have an idea of the density of the cataract because you need to plan your surgery, the extent of zonular weakness, and of course, the presence of vitreous in the anterior chamber. You need to do a gonio without fail because that will also give you an understanding whether it was trauma, whether there's an angle recession, whether there's pseudo-exfoliative material. You could even examine the patient in a supine position, which would tell you the extent of the dialysis and probably how would you plan? Would you go the pars plana route or are you going to go by the limbal route? You need to do an indirect, definitely in these patients, to assess the retinal problem. This could be associated, and a systemic evaluation would tell you some of these syndromes which are coexistent. So the most important thing is to look at the extent of zonular weakness. Is it a mild zonular weakness? Is it moderate? it is severe, or is it very advanced? Because based on this, you're going to have your surgical plan. But then again, just a slit lamp evaluation and the amount of zonular weakness which you've seen will not be enough, because there could actually be a greater damage, which is what you're going to realize on the surgical table. So then management, if it is in the early clearance, you could correct the myopia and astigmatism. But once there is cataract and aphakia, we need to definitely, we have advanced surgical skill techniques now. We need to go in and ensure that you restore the defective vision of this patient. If there is a coexistent glaucoma, you could do an iridotomy, or a medical management could be needed before you go on to doing a surgery. And if there is a defective vision, as I'd already alluded to, indications for surgery for ectopia lentis, is it cataract, aphakia, diplopia, or a nucleus which has dislocated into the anterior chamber or into the vitreous cavity. So then, when you talk about surgical correction, what is the extent of zonulopathy? Is it a progressive disease, or is it something, a temporary situation like a trauma or an iatrogenic dialysis? Is it then again the experience of surgeon becomes necessary? Are you going to go by the limbal route? Are you going to go by the pars plana route? Are you going to implant an AC IOL, an iris clip, an SF IOL, or you have decided to do a phaco emulsification? Then how are you going to conserve the capsular bag? Are you going to use a CTR? Are you going to take the help of the iris or the capsule retractors, or the modified CTR, or the CTS? So then, if you're going to do a phaco emulsification, the rhexis becomes the most important, paramount importance to ensure that the bag is preserved. So what is the challenge here? When you do a rhexis in an eye which has a zonular weakness, the challenge is you do not have the counter traction because the zonules are weak in a particular area. If it is a younger eye, the capsule is quite elastic also. So you need actually to decenter the rhexis, so that once the capsular bag is centered, the rhexis becomes centered. You need to use a highly retentive viscoelastic. You should initiate the rhexis from the area of intact rhexis, and you could use counter traction with capsule retractors, as I'm showing you schematically how capsule retractor being placed provides the counter traction so that you could go on with your rhexis. Again, but if you are on a laser platform like a femtosecond laser, you are not bothered about the counter traction of or the problems with creating the rhexis, or again, you could actually decenter the rhexis so that it comes to overlie the center of the capsular bag. The next important thing which you need to keep in mind is the stabilization of the capsular bag. You could use iris hooks, capsule hooks. Now, iris hooks and capsular hooks provide the antero-posterior stabilization of the bag, whereas the CTR gives the equatorial stabilization, and the armored ring segments come into play when you need to attach the capsular bag to the scleral wall. So these are the iris and the capsule retractors which you would need to know. But the importance of these is it is going to aid in your rhexis completion, as I had earlier alluded to. It is going to give you, by retracting the capsular rhexis, it aids in the CTR insertion to ensure that it is in the capsular fornix. Again, it ensures that the capsular bag is stable and there is a comfortable phaco emulsification and the lens is centered. And again, it reduces the chances of vitreous prolapse because the bag is stretched. So CTR is a compressible PMMA segment with a rounded eyelet. And what is most important for us to know is it expands the capsular equator, it buttresses the zonules, it redistributes the tension to the existing zonules, it keeps the posterior capsule taut during the surgery, it ensures that the IOL can be centered, it would also prevent shriveling of the posterior capsule. If it were lax, it could actually, there could be capsule contracture and it would decrease the prevalence of PCO. Again, it comes in different sizes based on the axial length. The capsular bag size correlates with it. So you need to ensure that once you have decided what is the size of the CTR which you're going to place, once the CTR is inserted, the ends of the CTR should overlap to provide a full circumferential support. Then, of course, if a CTR would suffice if it's a mild zonular dialysis, and if it's more of a non-progressive dialysis, a CTR alone might suffice. But if there is an anterior capsular tear or a PCR or an incomplete rhexis or a severely sublux bag, a CTR alone would not suffice. So just showing you how a CTR is inserted, like you can see that you could go into the side port, because if you go into the main port, the AC would shallow and that would increase the area of dialysis. And you should see that the CTR goes into the capsular fornix, and the very curvature of the CTR itself would ensure that it settles into the fornix. And then you need your second instrument to ensure that you're dialing into the CTR into the capsular bag, and it doesn't impinge on the angle because it needs to buttress the capsular bag. So the next thing is you could use an injector system as I'm showing. The advantage of using the injector system is you could directly inject it into the capsular fornix, and it takes care of some of the challenges with the CTR manipulation. You could have other capsular bag stabilization devices, as I'm showing you here. You could use capsular hooks to stabilize the capsular bag, and then inject viscoelastic, and then you could inject the CTR, and thus go on with the surgery. Now, whether you're going to use the CTR right in the beginning or later is something which you're going to decide based on the challenge which the surgery imposes or your surgical skill. Again, you need to have a good chamber stability, low flow rates, less fluid usage. You need to have adequate power, but it has to be a slow motion phaco, and the nuclear fragment should be visible and right into the center, and you should ensure that you have an adequate size rhexis. Now I'm going to show you some surgical videos just to help you understand, get a brief idea. Now this is a case of a dialysis which is nearly more than 4 clock hours. So, and a fairly dense cataract. So using capsular retractors to give that kind of a anterior-posterior stabilization, then go into the side port and then insert your CTR. The CTR, as I said, you need your second instrument to ensure that that last bit of CTR goes into the capsular bag and not impinge on the angle, and that is going to buttress and circularize your bag. And then, as I said, doing a chop technique would be ideal, more so in these kind of very dense cataract. You need to do a good hydro, because that itself would ensure that there's less stress imposed on the zonules. You need to actually separate the pieces, go gently about it, create a trench, use a stop and chop or a direct chop. A vertical chop would be more ideal. So you need to ensure that you completely split the nuclear fragments. The important thing for you to know is that till the nuclear pieces are there in the capsular bag, the posterior capsule is pushed well behind. So, but as you start eating the nuclear fragment, the posterior capsule is exposed. So there is a possibility of it trampolining. So you need to be cautious when you come to your last fragments, bring down the phaco parameters. Now, this is a case of a very small dialysis, and it was a traumatic cataract. So then, and again, a young guy. So the message here is, it is easy to do a centered rhexis in these eyes, but only thing, the elastic capsule. So you could actually mark the rhexis if you have those variant digital advisors, and then you need to and go about the surgery. But if you ask through the surgery, I have not placed a CTR in this case so far because it's a very small area of dialysis. So, but sometimes, even though it's a traumatic case and there is no zonular progressive cause, you could place a CTR towards the end of the surgery and then place a lens so that it stabilizes this. Then there are these capsular bag anchoring devices. It could be a Cioni or a double Cioni. Essentially, there's a significant amount of subluxation in this eye. So you need to be cautious and decenter the rhexis as is being shown. Then the capsular hooks are being there placed to ensure that the capsular bag is supported. A very slow motion phaco is done. And then the CTR is being injected. You need to deepen the anterior chamber so that the posterior capsule is well away. And then you do your railroading technique and ensure that the bag is supported. You could, again, I'm going to show you another video here, how this pre-op, how the bag was decentered and how it got centered at the end of it. You could have a single Cioni or a double Cioni, but you need to remember that these need to be placed in an empty capsular bag and the rhexis should be intact. There is a CTS which you need to know, like I'm going to show you here. This is a case where a Hoffman's pocket is being created and not a scleral flap is being created. So then you need to inject viscoelastic, a high-end viscoelastic, create a decentered rhexis away from the zonular weakness. You could place a CTR right in the beginning because there could be a fluid misdirection which could happen. But this was a very soft cataract. So then the nucleus was aspirated and then a CTR is being placed. And then one thing which you could do is, these are not a progressive kind of dialysis, but because of the asymmetric bag contracture which can occur, you could place an capsule segment in these eyes. Again, this is another case of very severe dialysis, wherein you are using capsular hoops, you're using a CTR, and you're using, again, Ahmed segments. Everything comes into play to ensure that you're able to center your bag and then place an IOL. What happens if it is, I'm not showing a case of an iatrogenic dialysis, which can be much easily managed. I would take you on to how you could deal with an alternate measure if there is a very significant subluxation as this. Now, in this particular case, this was an eye with severe pseudo-exfoliation and the bag, there's a lot of phacodonosis. You could probably do a phacoemulsification, but you could divert yourself and go on to doing an SICS surgery. And then as you can see here, that I've used a vectis to remove the nucleus. The pupil is quite small, otherwise you could inject pilocarpine. You need to do a gentle anterior vitrectomy. You need to make your side ports at 3 o'clock and 9 o'clock positions. And you could inject an iris clip lens in some of these cases. You could use an SF IOL or a glued IOL, but this is just one other alternate method. You could even do a iris fixation of the IOLs, which are different ways of dealing with a case where there is significant subluxation, where you do not want to do a gymnastics of using a Sioni ring and a CTS segment. It could be a case of a late IOL bag subluxation, which has to be kept in mind. Some of the cases we are doing extremely well come back to you after 10 years with significant IOL bag subluxation into the vitreous, wherein you need to remove it and go in and place a SF IOL or a glued IOL in these cases. So essentially, there are these ASI anchors, there are these glued capsular hooks, there are different devices which are presently available to optimize a surgery. Post-operatively, you need to be wary that there could be uveitis if there has been an inflamed eye, there could be a coexistent glaucoma, there could be a post-op capsule phimosis or a PCO, and there could be a capsule IOL bag decentration or a subluxation. So I would like to conclude stating that subluxated lenses need a systematic pre-op evaluation, which I had alluded to in great detail. A surgical plan is so important to ensure good outcomes. And we have to keep in mind that a long-term follow-up is mandatory, as we should have the logical thinking to anticipate problems related to IOL centration in these eyes. Thank you.
Thank you very much, ma'am, for a wonderful presentation. So before I throw the discussion to the panelists, to expert panel, I would like to ask, ma'am, what do you prefer nowadays, either a Sioni ring or the CTS? What is your preferred device if you have?
I would prefer, I think a CTR with a CTS, I certainly am not able to see on. CTR with a CTS would be the way to go in these cases, but there is very severe capsule bag dialysis. I actually just do not do any of these things, and I move on to doing a iris clip lens or a scleral fixated IOL.
So Harshul, if I can just intervene here. As far as the subluxated lens is concerned, the postgraduates either get it as a long case or they get it as a short case. And when they get it, then they'll be asked what all investigations do you do, refraction from the aphakic portion, phakic portion, all those things, they kind of become important. And then we come to the wonderful surgeries that, Chitra showed. She covered almost everything. I mean, there was nothing which was left covered as well as far as the surgical aspect is concerned. So I feel, except for the fact, that they'll be asked if it is less than 3 clock hours, what would you do to a low, a slow motion phaco? If 3 to 6 clock hours, what will you do? Use a CTR. I mean, these are the classic questions and the classic answers that the PGs are, given. And then if it is more than 6 clock hours, then you'll think of, your nylon hooks to anchor the capsule or to use a Sioni ring or whatever. But I think the surgeries were very beautifully covered, Chitra.
I think paucity of time, I should go on to our next speaker.
Yeah, I think Ramamurthy sir wants to add something. Yes.
Yes.
Please unmute yourself, sir.
He is dumbstruck when Chitra is presenting.
Yeah, she mutes you purposely.
Just one comment in the sense that, there must be youngsters listening to this, and I think going forward in their professional lifetimes, many of these gymnastics they are seeing of, capsular bags with 8 clock hours, 12 clock hours of subluxation being handled this way. it may go away because now secondary IOL implantation, the Yamane technique, cranial fixation, iris clip lenses, etc., which are quite stable during the lifetime of patient, are becoming well accepted. So maybe when faced with extreme subluxation, instead of involving yourself in all these complex surgeries, it might even be a good idea to go ahead and just remove that lens and do a secondary IOL fixation. I have had significant discussion with posterior segment surgeons, and we always used to believe that compartmentalization of the two chambers matters a lot. But they feel that if primary lens removal and a good anterior vitrectomy is done and secondary IOL implantation is fixed properly, then the ultimate outcomes are just the same. Now with Cortex sutures, etc., coming in, the stability of these lenses are also reasonably assured.
And don't forget the AC IOL, you know, which you are expected to answer in the exam. I mean, you can say talk about glued IOLs, Yamane technique, everything, but then AC IOL also remains an option.
The only challenge with AC IOLs is the sizing of these lenses. They have to be 1 millimeter above the wide to wide diameter. So obviously you don't have a library of lenses of different powers available. If the sizing is not proper, then they are prone to different complications.
And when they ask you how you are going to manage these cases, first thing is you can say that you're going to refer it to a experienced surgeon like Dr. Chitra, who will do a good job, and the gymnastics. Or if you don't want to do gymnastics, then probably how to do SICS and then manage it with an iris clip lens, iris claw lens, or a secondary scleral fixation. That is also something that Dr. Chitra showed. So that you have to keep in mind. And sometimes, like Dr. Ramurthy said, extensive progressive zonulolysis cases, even if you fix the capsular bag with a CTR and CTS over a period of time, these dislocate. So if there is progressive zonulopathy, then it's better probably to remove the bag and whole lens, do a proper vitrectomy, and do a secondary IOL procedure like a glued IOL or Yamane or four flange technique, as Dr. Ramurthy alluded. Very nice surgeries, Dr. Chitra.
Excellent surgeries. Excellent.
Yeah. We shall now go on to our next speaker, who's another trailblazer from Kolkata, an innovator par excellence and could rise to any challenge in cataract surgery. Dr. Suven Bhattacharya, you could share your screen. He is going to be dealing with management strategies in PXF and in small pupils.
Please unmute yourself, Dr. Suven.
I'll do that. Yeah, thank you. Yeah, so thank you, Dr. Chitra, and thank you, Academic Research Committee, for this opportunity. So I'll be speaking on management strategies in pseudoexfoliation and small pupil. So I'll be mainly talking about non-dilating pupils and intraoperative meiosis. So I'll be concentrating mostly on management. I do have a financial interest of the VX Pupil Center. I'll try to keep that to the minimum. And I do acknowledge the contribution of Dr. Neto Rosatelli and Dr. Deepak Megur, whose videos I've used over here. Now, pseudoexfoliation is a typical fibrillary white flaky material from the lens, which deposits on the lens capsule, ciliary body, zonules, corneal endothelium, iris, and pupillary margin. What's more important is it's associated with comorbidities with a small and non-dilating pupil, open-angle glaucoma in 50%, and a subluxated cataract. There is a high incidence in Scandinavian countries. Now, Chang and Campbell in 2005 described this wonderful condition called IFIS, which kind of gave us something to understand. What is important over here is that he stated that unlike the non-elastic myotic pupil, the IFIS pupil immediately snaps back to its original size following attempts to stretch it. That means it's an elastic pupil. So we come to the important question is, in the OPD or OT, what is the safe preoperative pupil size to eliminate risk of IFIS? Now, there could be any guess from 5 millimeter, 3 millimeter, 7 millimeter. Now, this is a paper published in 2011 by Alessandro Casuccio and co-workers. And the conclusion was that for a pupil 7 millimeter or smaller, the risk of IFIS existed regardless of alpha adrenergic receptor antagonist treatment. So that's 7 millimeters. Now, IFIS could be caused by a whole lot of predisposing conditions. There are a huge list of drugs. And more importantly, systemic conditions. Hypertension is a risk factor. And as we know, practically every alternate patient has hypertension. So no amount of history taking could be absolutely foolproof. Now, for those who think that in India, the problem isn't too much, well, This was a huge study by Shilpa Goel and co-workers, which suggested that prevalence of tamsulosin intake and IFIS incidence is higher in India compared to the global incidence. And current tamsulosin and alfuzosin intake and hypertension are important risk factors. So remember, hypertension is a very important risk factor. So if you look at the key differentiating features, now we have a group which is senile miosis, uveitis, glaucoma, and then we have pseudoexfoliation. Now they share a common problem is that they have a non-elastic rigid pupil. And then we have the IFIS, which is an elastic pupil. There is progressive miosis and erythroid. We do have areas of overlap in between all the three, which they will have subsets over there, but that is grossly way how you differentiate. Now in the elastic pupil, it's like a rubber band. You can use any pupil expander that will work. Whereas non-elastic pupil is more like a fibrous ring. It's like a string. You cannot stretch it. You can only tear it. So you need a strong and bulky expander or device to tear it. Now, when we come to the management, I divided into two parts. Part one would be preparation, where we talk of preoperative NSAIDs. And we must consider the fact that every eye is a potential IFIS candidate. The preparation is in the mind. Let's give our ego a break. Whether we can do a phaco through a 4mm or 5mm pupil is not important. If it's your own eye, you would like the surgeon to be safe rather than sorry later. We need to release posterior synaptic and peripupillary membranes completely. Intracameral injection of combination mydriatics and local anesthetics, that's a very good choice. If it works, very good. There are a lot of sugarcane, episugarcane, and various things which you can find in literature. I'll give you some references in the end. And we need to most importantly test and distinguish the elastic from the non-elastic rigid pupil. So when we come to the implementation part of the management, once we've decided whether the pupil is elastic or non-elastic, we decide whether you want to use OVD alone or iris hooks or a pupil expander. So if you use OVD, it's a viscometric and high molecular weight viscoelastic, Helon 5. If you're good at it and you can control with a low flow rate, then it's good. Or else we'll come to the iris hook tips and the pupil expander tips. And remember, there are certain post-op medications that we need to take care of. So preoperative non-steroidal anti-inflammatory drugs. Now, they inhibit surgically induced miosis due to iris manipulation and prostaglandin release. They do not have a primary role in pupil dilatation. We must remember that. They just inhibit the prostaglandin release. So when we come to mechanical dilatation of pupil, now pupil stretching, like I said, will not be effective in an elastic pupil that is an IFIS pupil, whereas controlled stretching will be helpful before we use an expander in a rigid fibrotic pupil. So we have a group of iris hooks or retractors, which is one group, which is very commonly used, and we must all know about it because that's something which we fall back time on again. And then we have the Mulligan ring and the BX pupil expander and the eye ring and other devices. So this is a little bit of a video about IFIS. Now this is a pre-2005 videos when we did not even know what is IFIS. So look at that pupillary margin and look at that billowing of the iris and the fluttering of the pupil margin. That's so typical of IFIS. Now this is a myopic eye, and I'm sorry of the video quality because there's a pretty old video, some of them taken from VHS. You might not have seen a VHS cassette also. So now that's very typical. You inflate the anterior chamber and the pupil becomes large, and again, it comes back on you. So now this is a case where I'm trying to show is despite iris hooks, we are having iris prolapse. So there is no device which is absolutely foolproof and guarantees no iris prolapse. What iris hooks and pupil expanders do is they ensure adequate pupil size for safe phacoemulsification. That's what it's doing over here. So the iris is frayed, the knuckle of iris is prolapsing, but we can go ahead and do that phaco surgery. And you can see that patulous iris, it's like a sail of a boat, and as you inject viscoelastic, and we need to protect the iris as we inject the IOL and the nozzle of the cartridge goes in. So that is iris hooks. And what I want to show is whatever device is used. Now here's a BX expander being used for IFIS, and this was a Toric IOL, a shallow AC, and we just had a slight hint of IFIS, and when we used the BX pupil expander, we did manage to get a good dilatation, but then iris did prolapse. So it's the nature of the iris, the extent of the IFIS that is there. It's a severe IFIS, the iris is growing to prolapse irrespective of what device you use. You may try a lot of low flow techniques and other things. Having a device which can come out through the side port is advantageous when you're having iris prolapse. So when we come to the medical management of IFIS, like I said, history taking cannot be foolproof. IFIS can occur in patients with pre-op pupils of 7 millimeters also, even without history of ever taking an alpha blocker. IFIS can occur more than 1 year after tamsulosin has been discontinued. IFIS can occur within 3 to 7 days of initiating tamsulosin, and stopping tamsulosin is really of no value, and in fact, it may cause painful urinary retention. And we must remember that often women are put on tamsulosin for urinary tract infection. A little about pupil expansion devices in IFIS. This is something I've come to understand over a period of time. If you look at meiosis and Aios prolapse, iris hooks or pupil expanders, what they do is provide us a constant pupil size and good visibility for safe phacoemulsification. Whereas iris prolapse, no device helps. Iris prolapse depends on IFIS severity and the pathological damage to the iris of due to stroma and muscles. So there is no credit to the pupil device when you don't have iris prolapse. It's just lower grade IFIS. So a favorable pupil expansion device would be one which requires small incisions. There's less leak and less iris prolapse, which is thin and has a low vertical profile. It allows more space in the anterior chamber for manipulation, and it can exist through a side post when iris may be prolapsing. So the choice of pupil expander will depend on how you wish to tear the rigid or non-elastic pupil. Like I said, an elastic pupil, everything works. So if you could do it with 2 Kuglen hooks, you could use something as thin as the BX, which is not a very strong device because it's hair thin, 75 microns. If you want to tear it with a pupil expander, you'd have to use a Mulligan ring or an APX or an I ring, which is a bulky device. And the downside is that it occupies more space in the anterior chamber. Now, if you're having a subluxated cataract, Dr. Chitra showed wonderful cases of subluxated cataract. There, I don't think a pupil ring is of much value. It is wiser to go in with iris hooks, which can asymmetrically expand the pupil in clock hours of interest. So you might like to relax the iris hooks in the non-subluxated areas and probably tighten it up in the subluxated area to give better visibility. If you're having intraoperative meiosis, iris hooks is a good choice always. And BX pupil expander would probably be the next choice because it can very safely negotiate under the pupil margin without engaging the capsular rhexis margin. The Mulligan ring is a little bit dicey over there. It can catch the capsular rhexis margin and lead to capsular rhexis tear. So we need to check the elasticity or rigidity of the pupil before starting. This is how we do it. Just inject with BSS through the side port. And if that pupil expands momentarily, that means that the pupil is expansile. It can be expanded. Now, let's see another example of the non-stretchable. Let's see, here inject BSS and the pupil really doesn't budge much. So this is a rigid or fibrous pupil. So we can stretch it with bimanually using 2 Kuglen hooks. And now we render it slightly stretchable to about 4.5 millimeters. And then it's very easy to use any device with the iris hooks, pupil expanders, rings, whatever you want to use. It's important to understand how we inject viscoelastic and where we inject viscoelastic, irrespective of what we use, iris hooks or pupil expanders. So when you inject viscoelastic in the anterior chamber and overdo it, you tend to flatten the iris on the lens capsule. And that is not very favorable. Instead, if you inject viscoelastic at the pupil margin, under the pupil margin, to just lift off that pupil margin a little, that facilitates your placement of the device. Keep the anterior chamber underfilled with viscoelastic. Iris bowing will help in hooking the iris and tucking the flanges. Overfilling the AC pushes the iris against the lens capsule, it plasters it against it. Injecting viscoelastic under the pupil margin to create space for the iris hooks and flanges works very well. Now, this is how we remove the fibrotic and sweep that spatula under that iris so that you can remove some total posterior synechia, and then you have rendered that pupil elastic, and you can use any device. I'm sorry, most of my videos are BX, though Dr. Chitra asked me to refrain from using too much of BX, but most of my videos contain BX as an example. But you could use any device once you've rendered the pupil expandable by removing that fibrous ring. So now I'll show you a wonderful video where I'll show you that the pupil size really doesn't matter. Look at that pupil. I'm so sorry, it's not playing. Is it visible?
Yes, yes.
Yeah, okay. So once we have removed that fibrotic ring, see the size of the pupil. It's less than 1.5 millimeter, but look at it. It's an expandable pupil. You can stretch it. See, removing that fibrotic pupil, Dr. Neto is a very skilled surgeon. So he removed that fibrotic ring so beautifully. And now with the bimanual technique, you don't really need to stretch this pupil bimanually. Here, it's rendered the pupil expandable. So you can use any device now. So it's not the size of the pupil, it's whether it's elastic or rigid is what matters. So how big do you want the pupil to be? Currently, I think any device that gives us an assured 5.5 millimeter pupil is good to do phaco. A 5 millimeter capsular access is good for all IOLs, and we are all skilled to perform phaco within in a 5.5 millimeter pupil, which will not get smaller. If you have that assurance, we're good to go. This is stretching of a rigid pupil with pseudoexfoliation and a hard cataract by Dr. Deepak Magur. You can see that pseudoexfoliation which has got stained by the trypan blue, and once you have stretched it, that pupil has become not elastic, at least it's become stretchable. So you can use any device, a strong or a weak device really doesn't matter. And like I said, a 5.5 millimeter is good enough for even a hard cataract. So we don't need a very big pupil, which is what we tend to kind of overdo at times. If you have intraoperative miosis, look at the pupil coming down as the phaco is started. Now, this is the time when we should take a call and probably inject viscoelastic under that pupil margin over that capsular rim to create space for any device, whether you're using iris hooks or a pupil expander, and that gives you that safety margin so that you don't engage that capsular excess margin. I'll be talking about a few iris hooks tips later as I show a video. So there you get a safe pupil size for phacoemulsification. Now, femtosecond laser assisted cataract surgery, there is an element of meiosis which occurs. And in this paper in 2015, it was shown that the pupil area decreased by nearly 30%, and it was correlated with the duration of laser pretreatment, the laser capsulotomy to pupil margin distance, and the patient age. And the trigger was prostaglandin release into the aqueous humor at the time of capsulotomy. And this is a paper by Tim Schultz and co-workers. So let's look at a few iris hook tips. We do the side ports first, always. Do not overfill, as I said. Keep the antechamber slightly shallow. And then as we make those nicks, I like to place small marks. So clear corneal incisions, 0.5 millimeter, not more larger. And I like to place some marks. Retract the stopper far enough. Hold with the hook sideways. Do not pull the hook all the way, just enough to give you retraction. And then we tend to overdo initially because we don't want to see the pupil as big as possible. So the capsular access should be as per plan. Do not get carried away by the larger pupil that we have. While introducing any instrument, remember the pupil margin is anti-flex, so need to be careful so we don't engage the pupillary margin and damage it. The pupil has been elevated to the limbal plane. It's come more anteriorly. So while removing, just hold the stopper, advance that hook, turn it sideways, and just pull it, yank it a little bit. It straightens momentarily, and it just walks off. Look again, hold that stopper, push that pupil hook, iris hook, and then just pull it out, and it walks out. And this is the rhomboid pupil by Oetting and Omfroy. I'm sorry, this is a very old video. That is a sub-incisional iris hook. Now, when we look at this, this was a rigid pupil, and I did not really take care to do a symmetric stretch before. So I kind of asymmetrically pulled the entire pupil to one side, and look what happens as I do engage this hook. The pupil margin rips apart, and we have a bad tear. Now, this is a very useful tip. You just need to use a second instrument to tent that pupil margin, and you can engage that iris hook and not engage the pupil margin without engaging the capsular excess margin. You can very safely engage a capsular excess, iris hook after a capsular excess. That's a very useful tip to use, at least in the initial days.
Thanks,
There's a little downside. Yep, I'll be finishing. So multiple corneal incisions, there's a risk of infection. There's a tendency for over-retraction. Remember that with iris hooks, these corner spaces are actually wasted spaces. We don't need the space, but we are stretching the pupil margin nevertheless. You could have cosmetic problems like marks and disfigured pupil. Now, there is an element of pseudophakic cystoid macular edema whenever you use a pupil device, whatever device you use, compared to when you do phaco in a well-dilated pupil, not compared to small pupil phaco. So there is an element of prostaglandin release, and there is CME, so it's better to use non-steroidal anti-inflammatory drugs in the post-op period to prevent any CME. So the take-home messages would be identify the pseudoexfoliation pupil and associated comorbidities, differentiate the rigid from elastic pupil. It's not the size of the pupil, it's the elasticity that matters. Remember that. Lower the threshold, lower your threshold for using iris hooks or pupil expanders. Please sacrifice your ego for some time. IFIS is associated with alpha blockers, hypertension, and many systemic diseases. So you really don't have a foolproof history. Iris prolapse in IFIS depends on severity of IFIS and not on the pupil device. and always have iris hooks and pupil expansion devices in the operation theater. That's a very poor excuse. If you don't have it, it's in fact very embarrassing. I would encourage you to look up this particular article, which I wrote for eauthor.com, phacoemulsification in small pupil. Thank you very much for the kind attention.
Thank you, Dr. Suven, for a very elaborate talk on small pupil management. Of course, I shouldn't have added that pseudo exfoliation along his talk because he couldn't have dealt with both of it. Maybe we could just discuss 1 or 2 points related to pseudo exfoliation. I'm sure it goes without saying that we, of course, now all of us do SPM for all our, majority of us do SPM for all our category of cataract evaluation, but SPM is absolutely mandated in a pseudo exfoliation. Would we like to place a CTR in routinely in our pseudo exfoliative syndrome kind of settings? That is one question I wanted to ask. The second question is keeping in view that you see a patient with a little late IOL bag dislocation, but still very much in the center. Would you observe these eyes, or would you do a iris fixation, or would you remove the IOL bag complex and place an IOL?
Okay, my answer.
I want the expert panel to answer this.
Yeah, fine, thank you.
Sri Ganesh, Ramurthy.
Yeah, I think cases of pseudo exfoliation, not all of them dislocate. So if there is no phacodonosis, if there's just pseudo exfoliation, I routinely do not use a CTR. But what I like to do is I like to make a larger rhexis, a minimum rhexis size of 5.5 millimeter, because many of this over a period of time go in for capsular phimosis. And if there is any zonulopathy as such with phacodonosis, then I would prefer to use a CTR. And sometimes now, of course, my thinking is it's better to put a 3-piece lens, because I've seen a lot of these coming back after 10 years or so with dislocation of the complete bag, CTR, IOL complex. And then you have to remove them and do a refixation. If you put a 3-piece lens, then probably you can do a technique like M&A, because you can refix the same 3-piece lens either with a glued IOL technique or a M&A technique. And now the thinking is probably it is better to put it in the sulcus, the 3-piece lens in the sulcus, and do a capture of the capsulorhexis so that the late dislocations are not there. So this is the recent thoughts in pseudo exfoliation. Excellent presentation, Suven, and congratulations on your ring. I've also been using it. A few of the points I would like to make while using rings is that if you have a small pupil, especially a rigid pupil, then don't try to force the device and try to expand it with the device, because I have seen cases of zonular dehiscence when you're pushing this device in one direction and the pupil is not expanding. And so the stretch on the root of the iris is much more, and you can end up with a zonular dehiscence. I prefer, especially in a rigid pupil where you can actually see fibrosis, if you're not able to remove the fibrous membrane, sometimes you're not able to do it, then you do microsphincterotomies, because if you try to stretch this, you can get irregular tears. So it's better to do microsphincterotomies with a fine scissor and then stretch it. This will kind of give a more controlled kind of opening rather than irregular tears. And then you can use the device, because most of these devices, especially if they're thin like Suven's device, they are more of retainers. So once the pupil is dilated, it retains it and keeps it in place rather than pupil expanders. I would call them retainers. The Maligan ring is more thicker and stronger, so it can push against the iris and try to expand it a little. But especially when you're using Suven's device, probably if it's a rigid pupil, then I would stretch it before using the device. In a 3 millimeter pupil, if I try to use it, then it's very uncomfortable. So that is one point. And the other thing is an IFIS, along with a pupillary expansion device, please use a good viscoelastic, because what happens is even if you put a pupil expansion device, then the periphery of the iris, it kind of floats up and starts prolapsing through your side ports or your main incision. So if you use a good OVD like Helon 5, then it keeps the periphery of the iris low, and you can use a low flow rate, and then you can complete your phaco safely, because once the iris prolapses out through the side port, then it keeps on prolapsing, and then you have a lot of iris chafing there, depigmentation, and it looks pretty bad post-op.
Thank you very much, Dr. Sri Ganesh. Welcome, Dr. Jagdish Reddy. I noticed that you are on online now in our presentation. I'm going to be asking you questions in the next for the PCR management. Because of paucity of time, I'm moving on. So please be hooked on, because I'm definitely going to attack you next. Our next,
just the questions that they would ask postgraduates. What is the pseudo-exfoliation material? How many of the pseudophakic cataracts with pseudo-exfoliation will go into pseudophakic glaucoma? So, these are the things that they may just ask in the theory. And it again comes as a short case only, it never comes as a long case.
I think only you can answer it, Namrata.
And what is the material which is there? It's a fibrillar material which is there. So almost 30 to 40% may go into pseudophakic glaucoma. The answer for that is, how many of them could go into pseudophakic glaucoma? And what is the material? It is the fibrillar material. These are the, theory questions that they will just ask.
And also, what is true exfoliation versus pseudo exfoliation?
Pseudo exfoliation and
what is glass blower's cataract? This is a common question which the examiners may ask you. What is true exfoliation and versus pseudo exfoliation? True
Just
exfoliation.
One practical tip, if I might offer. Suven showed so eloquently about injecting viscoelastic under the pupillary margin before introducing any pupillary expansion device, whether it's iris hooks or whether it's any device which expands the pupil. But please remember, as he showed very well, that very often these eyepiece cases have a tendency towards that. In eyepiece cases, over-installation of viscoelastic creates problems. At the same time, overfilling the anterior chamber also creates problems. In these cases, especially if you inject under the pupillary margin, there might be a greater tendency for the iris to prolapse out. In these cases, so there has to be just the right amount, because whenever there is pupil iris prolapsing out, there is immediate tendency for repositing and overfilling it. So it has to be avoided. The second point that need to be remembered, it is not the prolapse the iris which causes a problem, but it is the reposition of the iris which causes the problem. So please do not reposit the iris through the same incision. If in case it's prolapsing through the main port, go with the iris spatula through the side port and gently reposit it, and just inject a right amount of blob of viscoelastic to keep it down. Overfilling it is always counterproductive. Again, as was mentioned, right through the procedure, use slow parameters, low parameters, so that there's not too much turbulence and the effect of pushing the iris out of the various incisions that you make. Incisions you make have to be a little longer and more corneal, so that there's less tendency for the iris to collapse.
Thank you. We have very short of time, so we have to go on to our next speaker. Our next speaker is Dr. Suhas Haldipukar, who will be dealing on management of PCR. Dr. Suhas is a medical director of Lakshmi Eye Institute, a prolific surgeon, and amidst all his glorious achievements, is held with highest level of respect for the sheer magic in his hands and displays the most artful, most complex surgeries with utter ease. So we look forward to some brilliant teaching pearls in your talk, Dr. Suhas Haldipukar. On to you.
Thank you so much, Chitra.
I would want all of us to be strict about the 15 minutes time, and the discussions might have to be a little limited because we have 3 more speakers after him. Thank you.
Thank you, Chitra, for being so generous. And today my talk is so much more important for the postgraduate students. We all know that PCR is the most common and potentially sight-threatening complication. And we know that the target audience today is students, and for Phaco, those who are in Phaco training, sometimes this incidence can go as high as 11%. An ounce of prevention is worth a pound of cure, said Benjamin Franklin, and this holds so much true for a case of posterior capsular rupture. Now let's see it from a postgraduate standpoint. Things that normally come to your mind when posterior capsule ruptures: oh my God, not again. Or I'll get a scolding. I'll miss my next case.
The slides are not moving. Okay, you've not moved them.
They're not moved?
No,
The
the
slides are not moving.
first slide is coming. Only the first one is showing.
I thought he was still in his intro, so I was waiting.
Oh. Are you seeing my first slide now?
Yeah, now we are seeing your first slide. I think from the arrow on the left corner, you have to move it forward. Yes.
Are you getting it?
No, we're not getting beyond this.
Sir, stop sharing and share again, sir.
Okay. Yeah.
Yes. 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 It's all right now.
Yeah. The PCR is, like I said, it's the most common, and an ounce of prevention is worth a pound of cure, and it holds very much true for posterior capsular rupture. And like I said, when a postgraduate student gets a PCR, the things that come to his mind are, oh my God, not again, or I'll miss my next case. That means he's totally fixed on his own self. But instead, if he only changes his attitude, and the proper approach would probably be, what is my plan B in this particular case? How can I improve his chances for a better vision? How do I put it across to him and his relatives when I see them outside? Because this is something that a postgraduate student has to practice when he's doing cases, because PCRs are always going to come and they're going to really make your life terrible for the next day. If you look at capsular anatomy, we know that posterior capsule is the thinnest one as compared to the equator, where it is almost as thick as 23 microns. Now, when we do PCR management, we primarily have two objectives. The primary objective is a safe and thorough cleaning of vitreous and lens fragments from the anterior segment. And the secondary objective, which is also equally and more important, is a stable placement of intraocular lens for most appropriate refractive outcomes. Let's look at some of the predisposing factors. Looking at lens related, it could be an intumescent cataract, a mature white cataract, a black cataract, or obviously posterior polar cataract, which are known to have higher incidence of PCR. Sometimes even the age of the cataract matters, because longer the cataract stays there, it becomes harder, it really causes problem. Or when you have a cataract in an elderly patient, especially more than 80 or 90 years, where capsule is fragile and zonules are not very strong, or in an eye with previous vitrectomy. Some of the related to eye in general, if a patient has a deep orbit, prominent nose, reduced visibility because of corneal opacity, or a shallow chamber, very deep chamber, these are all cases where the chances of PCR tends to go up. And like the floppy iris that we just saw Dr. Sorin speak about, or the weak zonules, as in phacodonesis or subluxation. Obviously, for a postgraduate student, these are not the cases that they would really start with. And just to summarize, these are the cases where we would definitely be on a watch out, or probably when we are in our learning phase, these are not the cases that we would be doing. Even if it's given to you or your turn comes and you're going to operate on these, they really cause a lot of stress. So it's better to watch your seniors do them. Now let's take, this is a typical case of a posterior polar cataract. And we know a posterior polar cataract, when you approach, it's totally a different set of rules that we practice here, right from the size of the rhexis and the hydrodissection. When it comes to hydrodissection, obviously you will not be doing the standard hydrodissection. You would probably do multiple injections just to loosen the cortex, or you would prefer to do a proper hydrodelineation so that if possible, you could even get your endonucleus lifted out of the back and emulsify it in the anterior chamber. Or you would prefer to do trench, all these changes that you do when you're doing your posterior polar cataract. But one thing you would always remember is that you would always keep the pressure, the chamber filled and AC formed. And that's the reason after the epinuclear sheet is removed, especially when obviously you'd be using low parameters here. And when the posterior plaque gets dislodged, you're really relieved, because you know that it's not adherent to the posterior capsule and most of your job is done. But it's still not done, because till the end of the surgery, you have to keep the anterior chamber formed all the time. Now in this case, so far, all the principles were followed. And finally, when it comes to the last cortical fragment, it's removed and the PC looks so good and normal. So the irrigation comes out, and at the end of coaxial, I just take my coaxial out and I'm about to inject viscoelastic, and then you get the PC rupture. So what it means is, if you have a posterior polar cataract, there's also probably a possibility that the posterior capsule is definitely weak. Talking about situational related, predisposing factors like inadequate anesthesia, excessive eye movements, improper positioning of the patient for surgery, All these small things really matter enough to give you some problems. Now, if the patient cannot keep a flat position, or because of obesity or short neck, that can produce increased vitreous pressure with shallowing of anterior chamber. Now the question is, when do you get PCR? When do you get it most? Mostly when you're dealing with the last nuclear fragment. But sometimes during IA you get it, during PC polishing you get it. And sometimes you may start your case and right in the beginning of your case as well, you would get, because your phaco tip inadvertently passes through the nucleus. That means, in short, this can happen at any stage. Now, if you look at this case, this is classically the last fragment done by a resident. And if you look at the positioning of his phaco tip, you're obviously sure, because it looks so very unprotected. And what happens is, when you're on a last fragment, you have not lowered your parameters, but at least the resident has that presence of mind that he just freezes them. He is not in a rush to get his phaco tip out. And as luck should have it, the mentor is around. So what ideally is done, like it's done in this case, is before your phaco tip comes out, your viscoelastic goes in, and as luck should have it, in this case, the PCR that has occurred is a clear-cut punched out hole. That's in favor to the surgeon when he manages subsequently. Now you inject some more viscoelastic below the nucleus and try to lift up this quadrant and try to place it on the iris in the periphery. And with low aspiration and low irrigation, I go with biomineral irrigation aspiration, because there's a lot of cortex still left. Before I go with the vitrectomy, the cortex is aspirated as far as possible without disturbing the vitreous, if at all it's there. Then you inject viscoelastic again, and this time you go with triamcinolone just to identify whatever vitreous that has leaked from that hole. Go with a cutter. The cutter here would work at the highest cut rate that's possible on your machine, and very low vacuum. I would use 50 vacuum and a flow rate of 10 to 15. After getting the vitreous out, you go back with your biomineral eye, and small bit of epinucleus that's left, you will take out. Now you have a choice. You can put dispersive viscoelastic and continue with phaco, but what I prefer to do here is to play it still safer. So I implant or inject a single piece lens and try to place it in the sulcus. Now you might wonder why I'm putting a single piece lens. Because my game plan is, at the end of the surgery, I would get this lens into the back. Because the PCR is a punched out, well circumscribed hole. Now doing your phaco on top of the lens is a routine matter. But you have to be aware that you are close to the endothelium, so you will naturally be using low parameters. Now the next job now is to center the lens and then open up the pupil in the area that is required. That will show me how exactly I can get my haptics into the back. And using two-handed technique, your single piece safely goes into the back. The hooks are removed, lens is centered, viscoelastic is removed, and then, of course, any eventual case, you will do a proper suturing. Now, there are some cardinal signs of a torn posterior capsule. Now, the most important and the first one that you get is a pupillary snap sign, which is sudden jerky pupillary constriction during hydrodissection. There could be sudden deepening of the anterior chamber. There could be momentary pupillary dilatation or relative inability to rotate a previously mobile nucleus. Now, these are the signs that one should never miss. Like if you have never seen a pupillary snap sign, you will never really get it. Now, here is a classic case of a pupillary sign, just a routine hydrodissection, but it just gives you that. Now, if you are wise enough, or if you have picked up that sign, your course of surgery entirely changes. And if you have missed it, then the eventual thing that's going to happen is a part of the nucleus is going to sink. Now, nucleus drop can definitely be disastrous if you do not have an immediate backup, because you require to answer a lot of questions that can come from your patient or patient's relative. Now, in this, once you know that the PC has ruptured and the nucleus is bound to sink down, the surgeon is quiet because he knows that he has a backup support. But what he does is a clean job in the anterior segment, because he knows that he has got an intact rhexis. He can always put his 3-piece lens in the sulcus and quietly suture the wound and shift the patient to the next OR, where, as luck should have it, the VR surgeon is waiting. Now, this won't happen to many in the setups. So there, at the end of this, you need to answer certain questions and explain it to the patient. Did someone say something?
No.
All right. Then there are some more cardinal signs of torn posterior capsule. There could be sudden difficulty in burrowing into the nucleus and a tendency for the nucleus to display vibratory or tremulous movements. There could be tipping of one pole. And if all these signs are missed, then finally the Titanic sink is the eventual thing that we'll get. Now the question comes, when do you convert? If your decision is to convert, because the decision will depend upon the stage of cataract surgery and the amount of nucleus remaining. Then it will depend on the size of the capsular tear. It will depend on presence of vitreous in the anterior chamber. It will also depend on other accompanying risk factors like small pupil, loose venules, suboptimal endothelial status, and most important is the individual surgeon's level of confidence and experience. Now here for the postgraduate students, I would certainly like to tell you, if you have the benefit of a mentor around or your seniors around, if you think this is not within your comfortable, in your comfort level, it's always better to call your seniors to do it so that you get to see a much better, that's a bigger teaching, bigger learning than trying to do it yourself. Now, if the decision is to convert, suture the corneal incision and abandon it, make a new shell, limbal or scleral tunnel large enough to evacuate the nuclear fragment by safe expression, but at the end, secure the wounds tight because that's extremely important. Now, if your decision is to continue with Phaco in the presence of PCR, use dispersive viscoelastic before you remove the Phaco tip, then additional visco below the nucleus to lift it up in the AC, then cautious Phaco with low parameters, and while doing that, always resist temptations to further fragment the nuclear pieces because they tend to fall off here and there. Now, this is a case which I did several years back. It could be around 12 or 13 years back. Now, this classically shows you if my Phaco parameters are not well suited for a nucleus at the hand, like this is a very soft cataract. I'm right in the beginning of it. And then you suddenly see that pupillary, sudden dilatation of the pupil and a momentary deepening of the AC. Now, this is a
1 minute left.
Okay, this is a classic sign which tells that now since this was done 12 years back, that was the way I managed it. But today, if I had to do it, I would go by the pars plana approach and continue. And then I subsequently converted it into PCCC and tried to put a single piece lens in it. But today, my approach would be to go pars plana to deal with the vitreous because that really matters. But this is how, once you have isolated the pieces, make a pars plana incision, go with the cutter and clean it up. That way you end up losing less amount of vitreous. Now, this is a case done recently. If you notice carefully, you have that pupil expansion and the vibratory movement of the nucleus that you just noticed. Once you notice that, the next best thing you will do is to freeze the movement, inject viscoelastic, and then you try and inject viscoelastic between the rexis margin and try and lift the nucleus, because this is an entire nucleus and you still haven't really started Phaco. Get the nucleus out and try to inject some more viscoelastic below and use 3-piece lens as a lens scaffold. And once the lens is in the sulcus, your Phaco is just done as routine, except that you use less parameters so that your endothelium is spared. Then you do vitrectomy in front of the lens, and then you go behind the lens and do it. And once you have cleaned up the anterior segment, the lens is placed properly into the sulcus, pupil is constricted, and the eye is sutured. So, only last point, when you do cortex removal in the presence of vitreous, remember that the vitrectomy cutter is used in cut IA mode for vitrectomy and IA cut mode for cortex aspiration. And when you do cortex removal, you have to use low flow and low aspiration. And the recent updates are Passpana approach, endo-illumination, and 3-4. Thank you so much.
Thank you very much, Dr. Suhas. I mean, we could do without the questions because your talk, every slide gave so much information. Of course, missing out onto some good discussion because of paucity of time. Harshul, could you introduce the next
Yes,
speaker? Very nice talk, Dr. Suhas.
Thank you so much.
Yeah, it's always a pleasure to watch Suhas sir operating. No, he's such a meticulous surgeon. We all have learned a lot from him. Thank you so much, sir. So our next speaker is Dr. Ajay Paul, who is director and consultant at BBI Foundation, Kolkata. He's a prolific surgeon with amazing surgical skills, and above all, he has a very pleasant personality and always brings out positivity. Dr. Ajay Paul will be speaking on flex in cataract surgery. Can you unmute yourself, Dr. Ajay? Yes.
So first open the presentation, then start the screen sharing.
Presentation was open once.
Just put it on presentation mode.
Yeah.
Yes, sir.
Yeah, it's okay. Okay.
Yes.
Thank you. I think I'm audible. I'll be speaking on flax in cataract surgery, the femto laser assisted cataract surgery. So it's what I call it is an revolution in evolution. That's what I say. So flax has emerged as a useful adjunct to conventional phacoemulsification with the femtosecond laser pre-fragmentation, followed by the phaco fragmentation, the phacoemulsification itself. So basically, it automates all the surgical steps with increased predictability, the enhanced precisions because of the architecturally stable incision, the precise capsulotomy, and the nuclear fragmentation, and the closed globe pre-fragmentation with enhanced safety actually gives a leeway in doing challenging cases. This is the biggest advantage of this, as I see it. So it was in 2009 when Zoltan Nagy in Budapest, from Budapest, he first presented this paper at the annual meeting of the American Academy, the 1-year clinical experience with the new femtosecond laser. And this is where it showed that it offers a new level of precision and reproducibility in ophthalmic surgery. So it was basically, the concept was way back in 1991 when Chuck Dodick postulated the idea of anti-YAG phacolysis, and it was not a decade later that the interlace with the corneal femtosecond was introduced, and it was again a decade later, somewhere in 2008 and then 2009, 10, then the whole idea of femtolaser cataract surgery started. It was in the USA in Stephen Slade, and then following year, multiple the platforms have come in, the Lensa, the Catalyst, Victus, and as of 2015, some more than 10 million cases have been done. I have no financial interest. It's just that I use the Catalyst platform. Well, what's femtosecond laser? Now, this is a Nd:YAG laser of 1053 wavelength with the size of 3 micron. Now, it emits optical pulse in the duration and domain of femtosecond. And what's femtosecond? Is 10 to the power minus 15 of a second. You can have picosecond, you have nanosecond. So this is one of the 10 to the power minus 15. Now, what it does? It does, the femtosecond laser is such a ultra short pulse that there is no when this laser goes into the tissue, there is no micro cracking, no melt zone, no shock waves, as against the microsecond laser where there is always a colorate damages like micro cracking and shock waving, etc. So what it does is a photo disruption method where there's ionization of atoms, formation of shock waves, disruption of tissue with a very low influence for surrounding tissue. Now, what it does? Now, if you look at the how it works, the principle is a highly focused laser pulses. They do a phenomenon called laser-induced optical breakdown, and this causes a plasma of free electrons and ionized molecules. Now, these forms cavitation bubbles which expands, and these acoustic waves they expand, and the cavitation bubbles they enlarge, coalesce to allow a separation of the tissues. Now, if you look at these pulses, now pulses, if there are high energy pulses or high energy pulses, there are larger bubbles, widely spaced pulses. So you will have low repetition rate of the pulse when you are cutting the tissue, but you have a low energy, small bubbles, and more overlapping of pulses with higher repetition and less collateral damage. So this is the principle used whether you are using it to cut the lens or the capsule or the cornea. Now, this is a small video. As you could see, I think this video is not playing again. So anyway, just stop that video. So what it does, the 3-dimensional image actually does an anterior and posterior lens capsule. The 3-dimensional image as in spectral luminosity, the femtosecond laser, and then you have that whole thing going into the lens and the cornea and the lens and the capsule. So it does scans it. So it scans both the posterior and the anterior capsule. There is an accurate range of determination from limbus to limbus with high contrast, and it uses either a OCT or a 3D confocal structure illumination. So what it does, there is a variable numerical aperture. So how does it reach all these tissues? So the programmable aperture size in the lab, it actually aperture size changes the laser spot size automatically according to the tissue it cuts. So it could be the smallest size would be cuts the lens, then there is the capsulotomy, then the cornea. So 3 different sizes of variable aperture as it fires the laser. So the imaging could give you the side view, as you can see the capsular view. You could give a topographic view over the lens, so you can the thickness of the lens at what the region it will fire, and then the cornea side view. Then you can have the incisions at what you have. So if you look at the laser, there could be corneal laser and the cataract laser. There's a difference between that. If you compare with the corneal laser, wavelength is the same, but the pulse duration is different. The pulse energy is different, and the repetition rate is different, and the depth at which it goes for the cataract is also more than what it does for the corneal laser. So you do have those the LOIs, laser optic interface, or the applanating contact lenses. So in case of some platform like Lens 6, these are smaller with a smaller orbit. It is fit for smaller orbit. It's a separate. They have got separate reference plane for incision. And once it applanates the cornea, it produces slight corneal wrinkles. So as a result, you could have a better incision with this, but the capsulotomy might miss you sometimes. But in case of these the non-contact, non-applanating type, you have less IOP rise. There's a liquid interface there. So it's disadvantageous for small orbits and requires sophisticated imaging and corneal incision. So corneal incision may not be better in these, but the capsulotomy is definitely works better. The docking is where the cornea curvature and docking could have problem because of the steep corneas and corneal folds, and flat corneas, there will be difficult corneal. Conjunctival docking can have a little bit of redness or hemorrhage. The safety zone that you use, minimum distance around 500 microns, that is the depth of the nucleus, and the safety zone with the iris pupillary border also, you generally separate around 1 millimeter so that it doesn't hit the iris and give rise to meiosis of the pupil. And this is how the image, you can see this, the capsular, both at the in front of the capsule and behind the capsule, it starts and you have a clearance of almost 200 microns there. And this is the nuclear where you see there is a 500 micron difference in most of the, except the PPCs that will come to, as we'll show the video. And this is the corneal incisions that you can actually scan. Now about capsulotomy, actually the capsulotomy starts from this spiral pattern is applied first posterior to the capsule and advances anteriorly. This is how it's applied and then goes in front. In that case, if there is a bit of tilt, it compensates for it. Type of femto capsulotomy could be free floating capsulotomy, the microadhesions, the incomplete treatment pattern, and irregular complete pattern. And this we will show you in the video. So why is anterocapsulotomy so important? Why does it matter much? Because of the effective lens position, and we had talked on the biometry, how the lens has to be placed at the right position. And we know that this is the studies of Haggis and Hill, that the size of capsular axis actually affects the effective lens position. So you need to have a round, centered, and just smaller than the IOL. You have the shrink wrap effect, and that is where the effective lens position will be right, and that is why the biometry will do. So this is the biggest advantage of having a central, round, predictable rhexis. And this is the refraction, as this is a study shows that with the laser, the refraction is almost as much the distribution. If you see within the minus 0.25 to plus 0.25, this is the best one which is done with the laser as against the manual one. The circularity is measured with the manual rhexis. The mean circularity could be around 0.774, whether with the laser capsulotomy is 0.93, is almost equal, and there is a significant higher quality of circularity with the laser than against the manual one. And with the femto laser assisted refractive capsular axis, these are the newer things that have come in, where there is a notch there with the capsular axis you can do, and you can incorporate this with the image guided system, and you can have the rhexis also a bit notch where you can have the toric marker installed in that. The pattern of nucleotomy can be chopped, cylinder, hybrid, and matrix. We'll be seeing the different type of the patterns that we do. And definitely these studies of Palankar and Nagy et al. Has showed there is a 39% reduction of the CD when you are doing phacoemulsification, when you have actually pre-chopped the nucleus. There was a different pattern. And the impact of effective phaco time, this is a study by Burke and Dick, definitely in LOCS grade 3 and grade 4 cataract, there is a definitely reduction in the effective phaco time. Again, this study by Zakas and also there is a 51% reduction of average phaco power and 43% reduction of effective phaco time. And again, if you see the lens fragmentation pattern and the post-op inflammation, this study by our own from the Aims, Dr. Tithian and all have shown that there is a less endothelial cell loss and post-operative inflammation when you use the matrix pattern of emulsification. The corneal incision can be triplanar or biplanar. You can choose it as you do it. You can have the arcuate, laser arcuate incision can be uniform depth, precise, reproducible arc shape, and you can definitely correct, as we have in our experience have shown that up to 1.5 diopter of astigmatism can be corrected with the laser arcuate incisions. These are some of the intrastromal opening that the anterior ASOCT has shown, and it can be open also if this is where the post-op, it has been opened right into the periphery that will be showing. The clear corneal incision morphology, that the DMD, there is a lower incidence of DMD with these incisions as against the blade incisions. Now, something that is to be noted, I think this happened with the earlier generation of machine, the capsular block syndrome and the intralenticular glass. Today's machines or today's software actually reduce the amount of gas that is formed, the bubbles that are formed inside, but these bubbles can entrap and can give rise to the PCR, but this is not there in the present generation of machines. Intraoperative meiosis, as I've seen, the laser hitting the pupillary margin or the mechanical effect itself, release of prostaglandin in the myopic and pseudo-exfoliative eye. You can have intraoperative meiosis, but the best way is to use NSAIDs before the surgery. The contraindication as such is not known, but corneal disease, any corneal pathology, keratoconus, corneal opacities, the pellucid marginal degeneration, and advanced dry eye can be a contraindication. Pacemaker in situ, a patient who cannot keep his head or the back is not or there is a neck deformity where the patient, because patient has to lie down under the machine, for some time, and maybe a minute or so. So this is one of them. Then existing corneal implant can be contraindication, though it is being done now in pediatric surgeries and glaucoma. These are relative contraindication as such. So to sum it up, flax versus the conventional Phaco, the visual outcomes are similar. Studies have shown endothelial safety is more with the flax, and anatomical precision with flax as far as capsulotomy, incision, effective phacoemulsifying time and energy is definitely, it has shown, a lot of studies have shown that is definitely is better with the flax as compared to the manual phaco that we are doing. But there is no significant difference in terms of complication or vitreous loss. We'll come to show a bit of those femto advantages in challenging cases. 9 cases that I'll be showing that this is that real advantage is these rock hard cataracts. Rock hard cataracts, as you can see, I've done around 5 or 5.25 rexis. This is a free floating rexis that you see. I've done 6 chops, and then the separations become so easy as I'm using lesser power here, lesser energy is being used, and the emulsification is going on easily. I've got 6 chops, and that comes out easily. And in some cases, definitely I use this matrix softening. Now, this is again in the rock hard cataract. This is the biggest advantage that you don't have to pull your zonular, the pull in the zonules where you are separating or you are chopping. See, these are equally chopped, and the matrices that are made have made the lens softer. The amount of energy and the phaco time is definitely down, and you have a better crystal clear cornea the next day. White intumescent cataracts, we know that they can be a problem, especially when you are doing capsulorhexis manually. They can spread, or they can suddenly have a Argentinian flaxen. And in this case, you can have a little bit of micro adhesions left because some of the fluid might escape right in the beginning, as in this case, the fluid is escaped. But there are enough impression there. You can just complete the capsulorhexis very easily because there are lines you might have missed because the change in the alignment once a little bit of fluid escapes. But you can take out, and again, in these white and advanced cataracts, doing these softening actually helps and brings down the phaco energy. And in this case, where we have done the 6 chops, and the chop separation is easy, the energy used is
1 minute.
less. And that's how we go ahead. That's a small pupil. You can definitely have an advantage in the small pupil. As you can see, this is a 4.5 millimeter. I've used viscoelastic there, and the free floating rexis has come out. And again, I've not used any device here, but I can carry on my emulsification with that small pupil as I go. And again, we use little bit of viscoelastic, get the emulsified material out and get that advantage. And this is one of the cases where I use, as my earlier speaker, when I said B-hex in these cases, when subway and I have seen the rexis, the pupil is coming down, use B-hex and got away with it. The emulsification is done in that. And with reduced energy, as you can see, the energy is reduced, and I can definitely get in and put the lens of my choice. In this case, yeah, just a minute or so. And in the soft cataract, I do a visco dissection. As you can see, you can separate those the small pie, and so no longer you have to do all those, struggling with those, getting the deep bowl and not getting through it. In posterior polar cataract, as I said, I'm using in this machine, I'm using this bigger cubes, and there I am. I have kept a 800 micron, safety zone, and once I've done with it, there I've got the incision done and the lens, and there you can see I'm using a bit of viscoelastic, go behind the capsule, and then just do a bit of hydro delineation. And once I've done the delineation, I look at this, it can just suck it and take it out, and the pieces come out, and there I can just suck it, and the bimanual eye, just get it out and finish the surgery without any risk. And you can see that the PPC has come out, and just peel off and the peeling off is also easy. As you go, if at all you cannot catch it, do a bit of sideway. In post arcades also, this can work very well. Yeah, just the last way, and the post arcade. And I think subluxated, my earlier speaker has already shown. Thank you. Thank you for your present hearing.
Thanks for a very great detailed talk, including about the femto second laser principles and the different videos you showed. A paucity of time, we'll have to move on. Harshul, could you introduce the next speaker?
Yes, ma'am. Yes, ma'am. So next speaker is Dr. SPS Grewal, who is King of Punjab and Chairman and Managing Director of Grewal Eye Institute. He is an innovative surgeon par excellence and a great teacher. We are speaking on premium IOLs in cataract surgery. Dr. Grewal, sir, can you start your screen sharing, please?
Dr. Harshul, I don't see Grewal sir in this.
Oh, he's not there? Oh. Oh, then maybe
There's some problem. Yeah.
Connection must have been
I
lost.
would go on to our last speaker till we able to one of us. Harshul, could you call him in the interview?
Yes, ma'am. I'll just call him. I think you can carry on the discussion by the time.
Or
Dr. Minu, yes.
Dr. Minu, yes. It's a pleasure to introduce Dr. Minu Mathan, a senior consultant from Chaitanya Eye Hospital, Trivandrum, one of the most respected figures of Kerala State Ophthalmic Society and a surgeon par excellence. And we look forward to learning from him how to manage secondary aphakia and cataract surgery. On to you, Dr. Minu.
Thank you, Dr. Chitra. I think my screen is my screen visible?
Yes, it's visible.
Okay, so at the outset, let me thank Dr. Chitra for the opportunity and such wonderful discussions which have been happening for the last 3 hours now. So my topic is on secondary IOLs and correcting aphakia. So we'll deal with the indications, the patient selection, the type of procedure, and how to manage such patients in this short period of time with such a huge topic. So beneficiaries of secondary IOL are all patients who have potential to improve vision with spectacle correction and who have, by trauma or by surgery, have been rendered aphakic. So before planning on this one, we need to assess the presence of many things. The presence of vitreous in the anterior chamber and whether a total vitrectomy has been done or not. And the presence of anterior and posterior capsule remnants. Many of them will have posterior capsule or even anterior capsule remnants on which we could place posterior chamber IOLs. And then assessment of the iris, whether we can repair the iris or we need a replacement for that also. We always need to do the gonioscopy and IOP measurement and the angle and the AAC depth to see whether it's very shallow or not. Cornea assessment is very important, specular microscopy and corneal status of decompensation or opacities, which may not give best results if we do just an IOL. And presence of glaucoma, whether surgery needs to be done later or not, we have to leave the superior conjunctiva free, or whether a trabeculectomy has been done or not, when we have to leave the trabeculectomy free and should not touch on the bleb during surgery, and the IOP also has to be controlled. And look for conjunctival scarring where it is, and loose conjunctiva or free conjunctiva where it is available, and also look for scleral thinning and areas where we cannot touch if you are planning to do scleral fixation. And then later on, coming on to the fundus examination, if not visible, we need to do a B scan, look for detachments, IOLs, nucleus pieces, all those things. And if visible, we should look at the macula, preferably do an OCT, and always look at periphery to treat treatable lesions in the periphery before you take up for a secondary procedure. IOL power calculation, most of the time it may end up in the sulcus, and so we have to adjust according to that. And an orthoptic evaluation is very crucial, because some people will have a long-standing aphakia and they would have deviations, and they might end up with a diplopia later, and we may have to tell them that it may get okay or it may need surgery. And then we need to, because it is a secondary procedure, do a conjunctival culture and sensitivity, start pre-op antibiotics, and even prefer oral antibiotics also, because it is going to be a second, maybe a third procedure which you may be doing. And preoperatively consider Diamox and intravenous mannitol to reduce the IOP and have a very soft eye and a good block also. And so the options possibly going ahead is the secondary PC IOL itself is a first option. Many a time we will be panicky and we would not realize how much of capsule was left, and we'll think there is a huge rent, there is no capsule left, and just leave a faking. Later on, after a few days or weeks, we will find that the capsule fibroses and thickens, and you will see that enough capsule may be present, especially posterior capsule and even anterior capsule, on top of which we could place a PCIOL itself. I would just like to show this video. This is a trauma where lens has been removed, but then after a few months, when they come for a review, we find that there is capsule. If you notice, this is the inferior part. So if you have more than around 9 clock hours of capsule inferiorly, the superior one, even if it is not there, we can place a 3-piece IOL onto this, because I would suggest postgraduates to not try to do this in their postgraduate period. They should be watching seniors do this, and try to do these kind of procedures only when you are well versed with regular procedures in your practice. And here it is not good to rotate this IOL, because superiorly there is no support. So we support the lens in the sulcus and place the trailing haptic and use forceps to hold on to the capsule and hold it and place it into the sulcus without rotation. This capsule will hold. At the end, we need to do a tap test on the optic and see whether it is moving, and if it is not moving, it will be stable. Periphery, we have to look at very carefully the peripheral capsule. If that is intact and inferiorly it is good, these kind of IOL stay. So many cases we will be able to get away with placing a posterior chamber IOL itself. It's better if we avoid square-edged, anterior square-edged ones. You can have, there are lenses which have rounded edges on the anterior surface, and many cases we may need iris repair also. Will come to that. The second option is AC IOL. So many meta-analysis now have found that a well-placed, well-operated eye with an AC IOL does equally well as other secondary IOLs. So there is a lot of examiners will definitely ask for AC IOLs. Historical value is there, and still it is relevant if we do it right. So the choice of IOL is nowadays only this kind of an IOL, the Kelman 4-point fixation open loop multiplex IOL is the only one which is available, and that is the best one which is available now. So the first thing we have to do, all the assessment has to be done. The cornea should not be hazy, the endothelial count should not be low, a good vitrectomy has to be done, the pupil has to be round, the angle has to be definitely seen, no angle pathology should be there, and good anterior vitrectomy. We saw the PCR management talk, and I don't want to describe more on the vitrectomy part. And the pupil has to be constricted at least to 5 millimeters, use intracameral intraoperative pilocarpine. And then vitrectomy is iridectomy is very crucial. With the vitrector itself we can do 1, or I would suggest 2 at least, so that 1, if it gets blocked with vitreous sometimes, the second one will work. And without an iridectomy, it is very dangerous to place an IOL. Do not place an IOL. If you cannot find it, if it is too small, do another one using a YAG later. And the AC IOL, again, the sizing is very important. It should not be smaller. White to white diameter has to be measured at least 1 millimeter over the more than the size of the white to white. And the optic should be, there is a vaulting, optic should face towards the cornea, and while inserting, there should not be tuck on the iris tissue, and the pupil should remain round. And if it is small, you will feel that it is moving very freely in the anterior chamber, and if it is too tight, you will see that the haptic is very minimally seen. Both should not be there, and the open end of this one should not go in through a PI. That is very crucial. And if you are making incisions at the limbus, they have to be sutured. Ideally, they are placed through sclerocorneal tunnels. So as I said, iris tucking, it has to be lifted and left, and so that the 4 points of fixation fix at the angle, and the proximal haptic, or the haptic, whichever haptic, if it's an ECC, especially section with sutures, it should be placed away from the section so that they don't erode through, or they don't cause pains when the lid presses on the upper part. And displacement is mainly because of the undersizing, and if you undersize, it will move, and it can touch on the cornea, and it can cause corneal decompensation. And shallow anterior chamber can happen because of pupillary block. If you flip the angulation of the optic, if it is facing down towards the pupil, it can cause a pupillary block. And also sometimes the PI, if there is one and it is blocked with vitreous, also can cause pupillary block. And wound leak should be avoided, and it should be very well secured with sutures. But if not well done like this, it can cause prolonged intraocular inflammation, retinal detachment, short macular edema, glaucoma, corneal decompensation, the IOL stuffed with inflammatory pigments like this and cystoid macular edema. And just for showing people that if you just jam in some ACIOL at the during surgery without thinking like this, these can end up like this: corneal decompensation, fibrotic membrane going inside, iris adherent to the cornea, the corneal decompensation, glaucoma, pain, recurrent uveitis, and all those. And we have to expand this lens. And the haptic is so stuck between the fibrous tissue and the cornea and the iris that we have to cut the haptic and loosen it and then take it out and then wait for the cornea to get better, or even go ahead with the corneal transplant and a secondary scleral fixation later as another process. So unplanned, please do not place AC IOLs, but if done well, like what we described before, these are equally good IOLs. So an ideal IOL, as I said, no minimal contact with the drainage angle. It should be at the scleral spur ideally, but we have to place it in the angle. No iris chafing, endothelial touch, and it has sizing is very important, that it has to be white to white is measured and 1 millimeter more than the white to white. This is how ideally it should look. And the third option is iris fixated lenses. Iris can be sutured to the iris or iris clipped. These are phakic IOLs, and Dr. Chitra had shown already that these lenses, which are now made for aphakic people, it can be placed underneath the iris, and there is a clock here at these 2 points, which can be, iris can be enclaved into that. And these are very good lenses, but foldable ones are not available right now. We need to have a larger section, and the foldable ones can be used, 3-piece ones can be placed under the iris, and they can be sutured with 90-prolene. And the prerequisites are the iris should not be damaged too much, no much of iris tissue loss should not be there, the pupil should be round, they should not be very fibrotic, and no vitreous in the anterior chamber. And there is some suturing technique which we should know. It's good for drop lenses which can be brought up and sutured to the iris, and especially when there is corneal scarring in the periphery and all those, we have to locate places where it can be sutured at any clock hour. So it can be located at easily at places where you can have good visibility. And especially when there is scleral thinning and you cannot make flaps, or you cannot want to cut the sclera, this is again a better option. Technically, it is just placing the haptics underneath the iris, because there is no support there. You cannot place the whole lens below. The haptics have to go under first, and then the optic is on top, and then you pass 90-prolene straight needles are available here. It has to be bent, and it's a double needle one. So it goes through the cornea and then engage through this iris, engages the haptic, and then comes out on both sides. And then the haptics are it's sutured. So inside you can suture it within the anterior chamber, or the knots can be brought out and it can be sutured. You can multiple ways of suturing the haptic there. And once before tightening the sutures, we can put the optic back down so that we can make the pupil more round at that, because by not allowing the iris to get entangled in the knot. Otherwise, once you tighten it, this can be gently pushed behind the optic, and you get a relatively round pupil. And I always do a PI also after the procedure. And the other one is scleral fixated IOLs, which are in vogue now, and they can be sutured or non-sutured. It's done when there is total absence of posterior capsule. Posterior segment assessment is very important, anti-vitrectomy, and you need not be a VR surgeon to do this, but then VR surgeons also do this after a full vitreous base shaving. It can be 4-point fixation or 2-point, or no suture fixation. So no suture fixation is basically do the glued IOL technique. There can be many modifications which are to that. Basically, it's going to be an intrascleral haptic fixation. So you need a 180-degree opposite scleral flaps, which may not be needed in some other techniques, but scleral flap is created, and then the chamber is always formed with the fluid. IC maintainer is placed. Sclerotomy is made 1.75 millimeters behind the anterior limbus, and using microforceps, you can catch the IOL haptic. The 3-piece IOL is always used, and one haptic is exteriorized and secured on one side. The other haptic is also introduced, and it is also exteriorized on the other side. And along the path of this haptic there, we make intrascleral pockets with either a 1 millimeter keratome or a 26 gauge needle, and it is tucked inside. Nowadays, the Yamane technique is also getting popular, where you don't have to cut the conjunctiva or the sclera, and it can be brought out through a 2 millimeter passage through the sclera, and then the tip can be flanged, and it can be pushed back into the sclera, and with the conjunctiva covering it very well. Once this is done, the flaps are closed either with sutures, or you can put fibrin glue, which doesn't actually do anything to the haptic, but it closes the flaps. And once the air is placed so that this is dried, you place the glue there, and it is tied down, and the conjunctiva also can be glued. But then I put one suture to the edge of the conjunctiva also now, because I don't want this one to open up and the flap to get exposed in the early period. So the last one will be sutured IOLs. So again, we make flaps like this. You can be triangular, it can be rectangular, 180-degree opposite, and using this straight needle and this 26 gauge needle, both going under the flap, it can be brought out to the other side. So this thread will be there in the nowadays we use 90-prolene, and also Gore-Tex is also available, which is which doesn't degrade that much. And once this is pulled out, you can cut this end and tie that to the ends of the IOL, and the IOL is put back inside, and the sutures are knotted under the flap. So just to show you fast, this is a long one. This sclera totally scarred conjunctiva all along, cornea sutured, bad situation. I'm just showing this the Hoffman's pocket, which is already shown here. Without cutting the conjunctiva, you can tunnel back onto the sclera. This is what is done. So 3 into 3 millimeters, you tunnel back from the cornea into this one, and then pass needles through that, and then bring out the needle. And as we showed in the figure, this is tied.
Not seeing, Minu.
Pardon me?
We can't see the video.
Video is not seeing. Oh, oh, because it is being run as a separate video. That is why. Okay, but I don't. What should I do for this? Because the video is being run as a separate video. That's why. Maybe you'll have to skip that.
You have to close this and
but I think that was the figures have shown it very well. The images have shown it very well. The technique actually doesn't make much of a difference. And so to end, how to tackle a complication during a procedure and coming on to a secondary IOL later is what we need to do. During a surgery, don't be in a hurry to put in an AC or a PC IOL without estimating what the extent of damage you have caused. And so never panic, and the surgical modifications which you need have to be carefully seen. Use the help of your mentor, please. Because here you see a trainee operating. There is a PC and you can see very well here. And the IOL is placed, we could easily place it into the sulcus or into the back, but then it exactly goes into the PC end if you place it in a, see the hands shaking and trying to catch the IOL. Once you try to catch the IOL by yourself, see now you're trying to push it more down than trying to catch it and hold it, and right by looking at it itself, it will just drop. So please use the assistance of your trainer when you're having a problem like this, and see multiple cases being managed, and then use triamcinolone assisted vitrectomy, good iridectomy, good cleanup, and then wait for some time and assess properly, and then get on to the secondary procedure later. Thank you very much.
Thank you very much, Dr. Meenumarthan. When would you operate after a primary complication? Would you suggest a time frame for the, supposing you had a primary complication? Would they do it within the 6 weeks period, or do a secondary IOL after the high haze? It's a simple question, because we'll have to conclude.
Within 6 weeks is more than enough. 1 month is okay. 1 month is okay if you assess your posterior segment well, and there is nothing at the on the retinal periphery, and your corneal edema has cleared well. 1 month is okay to operate. But if then the corneal edema persists, and if they see some horseshoe tear or some traction you have caused in this one, then they have to treat it, get it settled, and then proceed after 3 months. 3 months used to be told before, but then there's nothing like 3 months, or patients will have to be, if patients agree, there's no harm in waiting for 3 months, but then 1 to 2 months is more than enough.
Arshul, are there any questions before we conclude? Anything?
Yeah, no, ma'am. I think we can conclude.
So it's my time to thank one and all of you for your major contributions made for our Remember webinar. My deep felt thanks to one and all in the expert panel for being with us and giving significant contributions. Thank you each and every speaker here for their wonderful talk, which I'm sure would have been very informative for the postgraduates. There are quite a few of them who are attending right to the end. Thank you, ARC members. Thanks so much for enlivening the webinar with your abundance of knowledge and skill. My special thanks to Aios admin under Mr. Kripal and his team, Mr. Sunil for the technical help throughout the webinar, Sai and Manjula from Neurotech for the constancy of support, Mr. Nikhil and his entire team of Entor for sponsoring all ARC webinars, and every single attendee who has made it so worthwhile to have come back to you all time and again with our webinars. Thank you, one and all of you. Thank you very much.
Thank you, ma'am.
Thank you, all of you.
Thank you.
Thanks a lot.
Thank you, everybody. Thank you, Chitra.
Thank you. Thank you, Ganesh. Thanks,
Good night.
Ajay.
Good night,
Thanks, Minu.
Good night.
Everybody.